So I have Carol here, and Carol's 68, and I asked Carol what bothers her, and she said this area around my mouth, which we have so many patients that come in with the same complaint. She's never been a smoker. She feels like she looks like she has been a smoker because of these perioral rhytids, right? She saw somebody several years ago who said, you need a facelift. She wasn't ready for that, so she didn't have anything. So here she is, and we're doing a little treatment around the perioral area. You can see that Carol does have pretty significant rhytid. She has some elongation of the upper lip, which filler will not address. You would need a surgical lip shortening for that. But we can soften this significantly. I was asked to do PRP, so I'm actually mixing a little bit of PRP with Restylane Silk. This is a small molecule hyaluronic acid. What I would do in practice is a little fractionated resurfacing on top of that and put the PRP on top as well. But all those lasers are put away from yesterday, right? So we're not doing that today.
Do you do the same thing?
Yes, I do. And I'm, with my aging eyes, I'm going to turn your head away from me a little bit. So I always put when I tell patients to turn their head, it's another tip, I always have my hand on their head because they always want to turn towards me, towards the needle, and we always want them away, even so that's a completely normal response. Let's see if I can. So I had an introducer needle, and I am using a smaller cannula with this demonstration, and usually I use a 25 gauge for just about everything in my practice. The exception is in these perioral lines. I'll often use a 27 gauge, and the reason for that is it just slows down the injection. This product flows very smoothly and nicely, and it's nice to have something to basically slow that down. You want to be very superficial with your cannula. So you can tent your cannula up. If you go too deep with this product, you'll lose benefit and you'll have more swelling. So we're going to.
Is Restylane Silk your go-to for lips?
So the question is Restylane Silk my go-to for lips? It is a nice product for non-volumizing. I do use a lot of off-label refined in the lips as well, particularly to give just a little more structure to the actual lip line. But and even people who don't want volume in their lip are quite happy with the small bit that you get with something like Refine. But Silk is quite nice as well because it just basically lays down very tiny particles in the area. So it depends on, sometimes I'll layer both. So I'll do a little Refine in this area for a little more structuring underneath, and a little Silk on top for some fine tuning.
So would you describe your treatment?
Yes.
Would you describe your treatment there as immediate sub-Q?
Immediate sub-Q, yes. So you want to be basically scraping the dermis with this. And the deeper you are, the less effect you'll have on these fine rhytids. And again, the more swelling and problem you'll have. Which I didn't realize is that this cannula is not 1.5 inches long. So I might switch this out and put a little more in the medial aspect.
One of the things that I thought about the cannula, like all the other arguments aside, safety,
Mhm.
but it gives a subcision, and that might be very useful. I don't know who had a feeling on that.
I absolutely agree. I feel like when we're scraping the bottom of the dermis, we're subsizing it and creating a collagenesis, basically. I think that's a great point. And I'm going to switch over to a little longer cannula here. Sorry about that.
So you just to review the preparation, the PRP prep, is that something that you do at the beginning of the patient visit, or how does that work?
Yes, so the PRP takes 10 minutes to spin down, and basically that's perfect timing with the patient numbing in the office. So it really doesn't add any additional time. Generally, one of my assistants will draw the blood and get the patient prepped and ready to go so that everything is kind of set up at the same time. I'm going to try this a little longer because I wasn't able to reach into the metal. Sorry, these are different cannulas that I'm. I think I just.
So what is that, do you want to describe the cannula that you, what's the size of that?
Yeah, so this now, I've switched over to a 25 gauge, 1.5 inch, which I prefer longer needles, longer cannulas. I just like to be able to reach across the face. The last one I had was, I think, 5/8 or 1 inch, so I wasn't able to reach this medial portion of the lip. This is, and 25 gauge honestly works very well in this area as well. I had an additional, so I'm just going to switch out my additional product here.
And either practice for the majority of the time it's cannula or needle or the mix.
Yeah, that's a great question. I use a lot more cannula these days. I still like needle with Sculptra injections, and almost everything else I use a cannula. It is, sometimes when we're chasing these fine lines afterwards, I will use a 31 or 32 gauge needle, which you can't really kind of get into these lines quite as nicely with a cannula. So I do a little fine tuning. I'll treat the filtral columns with a needle afterwards. So I don't completely get rid of my needles, but having the cannula just reduces, of course, bruising. It's a little safer. And it also, I think, controls, because these are long, I like the long cannulas, it does control the flow a little more nicely and decrease the number of insertion sites.
So if so you're alternating the silk and then the PRP?
So I have the silk and the PRP mixed in together here.
They're in.
Yes. So I have a little bit of PRP that is, I put in 0.5 to 1 cc of silk. With the thought that it will speed up kind of the healing process for her, number one, and it also seems to, there's a possibility of increasing the collagenesis, which she needs, should be beneficial for her.
Is that ratio, have you tried other ratios too? The 0.5
Yes.
to 1, is it
Yes.
1 to 1 or
Yeah.
what?
Yes, so it depends on how much PRP I have and what I'm using it for. I mean, but usually I do like the a little more silk than PRP, so I certainly wouldn't use more PRP than silk. Otherwise, you're just going to get too washed out. But enough to kind of distribute in the tissue. Yeah, and there's not an exact science to that, no. I'm going to come
And
up.
these are the soft fill cannulas, which we have an exhibitor here who has cannulas, and they come in a variety of gauges and sizes. And this is is this a 25 or 27 gauge?
So I started with a 27.
Yeah.
The 27s are a little short, so I could not, with one insertion point, reach her filtral column, so I switched it over to a 25. I am going to use just some straight PRP. There's always a little extra left over just to give her a little support to this cheek area and under the eye. And I would typically do this mixed with a little Sculptra. But this is straight PRP. And PRP is, I think, sorry about that, you doing okay? You can feel it. Lastly, I'm going to give her some really deep dermal sub-Q plain injections into these cheek rhytids, just very small aliquots. Go ahead.
So I don't want you to stop working, but this is not really too far away from the original vampire description with the fillers.
Yeah, no, that's correct. But I personally don't like the term vampire facelift.
Yeah.
In fact, I don't like it at all.
No, it was poorly chosen probably, but that certainly got a lot of popular reps.
So Serena, I missed.
Yes, go ahead.
Do you use a particular kit with it, or do you spin it down and mix it with the resin?
Excuse me?
So I missed while I was injecting.
Oh.
Do you use a particular kit to make your PRP, or do you just spin it down and then mix it with your resin? So.
Oh, I just use a female
Okay,
adapter.
so you just spin it down and then
Yeah.
Okay, gotcha.
Yeah.
So you don't mix it with all that, one of those calcium sweats.
Well, the calcium, actually, so the PRP, the tubes basically have that calcium substrate to separate the blood out.
Like a
So-
serum separator too.
So it's a separator tube,
Yeah.
and the blood ends up on the bottom. You have your serous yellow clear fluid on
It's
the
different than a
top.
regular serum separator.
Yes, yes. This is a Helion. We had,
We wanted to let Dr. Lacombe just finish up his comments so we could.
No problem, yeah, so we can, so I finished up here.
So Marie here is a very youthful 45. I always judge it because she's younger than me. She's got a little bit of hollowing underneath her eyes. She had injections underneath her eyes, you said a little more than 2 years ago. Okay, she's used to having a little bit of injection in her lip and a little bit in the corners of her mouth here. In general, she's got good skin quality, good firmness to her skin. She maintains it. She works a little bit in the industry. So because I'm going to be injecting some Voluma later on, so we sort of split it up between the two, because I tend to like to inject Voluma in the cheekbone and the eyes area under the eye. I'll go into a little bit of that as we go through it. I personally am not a big fan of Juvederm under the eyes. I know that people have lots of different choices for things, and so obviously that's why we're seeing a variety of different injections and injection types. But I really like it for around the mouth and in the corners. And so that's why we sort of split it up, and so you'll see me using one vial of each. And so the injection techniques are the same. And so my personal technique is that I tend to block people. Not everybody does that. You'll see Serena, she's got numbing cream on her patient. But I've already done that, so you don't have to watch me do that. I tend to start injecting from the top down. And if we see here, yeah, so tilt your chin just down a little bit, no, down for me, and then look straight ahead there. You can see that she's got pretty good hollowing underneath her eye and through here. The edge of her bone is right there and right here, and all the way out to here. And so my injection technique is one that is based upon injecting down right on top of the periosteum. And so you'll see me using a bimanual technique where my finger is going to be touching her right on the edge of the bone here. And I'll actually be distracting the tissue up a little bit so I can inject through the firmer, thicker tissues and then land right on the top edge of that bone. And I find that that tends to avoid a fair amount of bruising and make sure that I get on the right position all the time. I tend to start laterally a little bit through here and come into the thicker skin, angle upward, and then I land right on the bone. I make sure I'm on that bone and slide upward just ever so slightly. I'm underneath the tissues and do small boluses. How you doing there, Marie? All right. So small little sort of BB size or pea size boluses right along the edge of the upper portion of the lateral orbital rim. Working my way medially. So see, I'm not taking my needle out and moving it, making a lot of little puncture wounds, so minimizing the trauma. I can feel each little tiny bolus as I inject it, so I know exactly where I am. Borrowing a phrase from a friend of mine, Charles Boyd from Michigan, this is the smart finger here, this one. So I know exactly where I'm going. The back hand here is just doing a little pushing, doing all the manual labor. I come out here, grab my 4x4. And then I just hold a little pressure here, do a little gentle massaging. Not really to move it around, but just make sure it's smooth and even. I like to hold pressure because that helps to sort of prevent bruising. And you can already see a little height coming up through here. And then I'm going to come around with a second injection point right about here. So as I'm doing that, I'm holding pressure with the thumb to prevent bleeding where I just came out of. How you doing?
Good.
You feeling much of anything? A little pressure maybe?
Nothing.
So right now we're using Juvederm Voluma. I tend to use that because people don't like to get injected in their eyes, and I find that particular product tends to swell less in this particular area than its counterpart Juvederm Ultra Plus. But I will be using the Juvederm Ultra in the lower part of the face. So I'm going to come now, so I've done this sort of more medial portion through here. I'm going to do a little injection to the lateral, a little indentation out through here. This one you'll feel a little bit more here. So again, I have to really come laterally, come up and around the lateral curvature of the lateral orbital rim and come more vertically as the orbital rim becomes more the lateral orbital rim as opposed to the inferior orbital rim.
And in this case, Victor's using this product straight without any additional
Right.
anesthetic, which this product does contain some lidocaine. And
one of the things I've been doing more lately, which we're not going to do in this particular case, is taking, you can see her whole face here, taking the product once I've finished up and out through here, and then blending it all the way out to the lateral orbital rim as well. She's pretty young, she's pretty full, but it also helps to lift up the cheek a bit and blend it out laterally, so that if someone's not budgetarily limited, or if we build it up over time, it really helps to create a more natural contour, especially in women. Men, we don't like to get quite as wide in, but it's a real nice touch.
and that's a different syringe design that I think Allergan came out with.
Yes,
all
this
their
is-
products using this new phalange plunger, and what do you think about the design of the
I think it feels nice. I don't think it's out in the Juvederm heritage products yet, but I think all the Bow products, the Bobella, the Volure, and the Voluma have the new design. So here's the Juvederm product, which has the original design still. But I think they are planning to roll it out in all of them. So you see how I'm holding a fair amount of pressure here? And that really is to help prevent bruising. So what I would ideally do is go and inject the other side respect to time, we'll probably move to the lower part and I can finish that part up afterwards.
And what do you tell your patients to expect their maximum swelling and,
So usually the maximum swelling is tomorrow morning. So we have some swelling tonight. And then in the lower eyelid area, we tend to see swelling happening for 3 to 5 days, sometimes mild swelling, even up to 10 days to 2 weeks, depending upon how much they tend to retain fluid.
So just to be clear, that was all on bone injection?
All on bone injection. I'm personally loath to put injections in the midplane or into or near the muscle. In almost all cases, where usually it looks really great right away, but then 3 to 6 months down the road, we end up getting that purple sort of, I don't like to call it tindling, but sort of a watery, boggy sort of purple, especially in the medial areas. And more times than not, I've come back with people and they said, oh yeah, I've never been injected under my eyes. And then they think back and they've always been, and we have to go in and dissolve it. There's a few cases where I have gone in with a little bit of Volbella, and someone who just keeps that little tiny bit of a ridge underneath there for whatever reason. There's a ligament or a tendon or something that's holding it down, and I just sort of layer a little tiny bit in through there. And that has been successful. I know that people talk about a sandwich technique where they go some deeper and some superficial. That's not my preference. Okay, so here we've completed that one side, and chin up, down for me actually a little bit. Okay, so look straight ahead there. So we've sort of created more height to the cheekbone in through here, okay, and filled in that hollow underneath her eye. And we still have much more hollowing here underneath this side of the eye. And chin up for me now.
I would also comment that that lateral orbital injection is often overlooked but really important, especially as we know from past colleagues, that we get so much lateral orbital hollowing and extension of the orbit. If you forget that injection or you're fearful of that injection, you miss a rejuvenative option. To me, it's even more than just cheek, it's replacing that volume loss of the lateral orbit.
And this part actually tends to swell less, and it's really easy. And if someone's sort of fearful or they've got a lot of, something to do, you can get a big bang from coming right up in this area through here, bringing it up to here, and even out to here. And that really gives somebody, so let's say somebody, wants just one syringe or one little part today, they can always come back and I always tell them, if you like it while it's swollen, you always know where to find us. We can always come back and add more in this area through here. And that really gives you that sort of Gigi Hadid cheekbone or something that's a little stronger and more attractive in that area. So I think this part's very important, and it actually blends up all the way up and around to here and into temples. So temples is also a very nice area to do that people always overlook. It rarely swells very much. It's relatively easy to do. It makes a huge difference in people who are, oftentimes conservative, but really appreciate those subtle differences. So the next thing we're going to do is a little bit of the lip here. We'll try to make this one quick here. She has very beautiful lips. She doesn't have a lot of volume loss. She has a few little lines here on the upper lip. We're going to focus on a subtle but nice improvement here. I tend not to do it a lot at the lip border. I try to go underneath the border. A lot of the younger girls these days are really looking for fullness in the red part of the lip. I try to do some threading here right in the medial portion. Medial volume is much more sought after these days. She is in her 40s, so she does have a few little lines here, so I do a little threading this portion here without trying to make it too thick.
You're using Juvederm?
I'm using regular Juvederm here, yep. She's got a little wrinkle right here we'd like to go across in order to keep that from crinkling up on her.
This is the Ultra or the Ultra Plus you're using?
This is the Ultra, I'm pretty sure. But for most people, it's relatively interchangeable.
And you're using a 30 gauge needle there?
Yes, the one that comes in the box. Okay, this is the most important part, I think. I'm going to sit as long as it's not blocking. Yeah, we're pretty zoomed in here. Good, you can stay where you are, good. This is the part that is sort of the home run, because this is the downward corner here. And oftentimes this leads to the resting B face. And coming across here, we can help turn that up. I'm relatively close to the dermis here. I was going to jolt my phone just for me. So see, I'm creating a little fan here right at the corner.
So I'm just gonna make an announcement because I was watching our live streaming and this is private live streaming this year. And by the way, with photography and videos. Let's see back here.
She says she likes the block.
Ridiculous. I can't talk.
My assistant.
I can't even talk right now.
She's my assistant, that's all. But I'll stop.
But we will do, the idea is by invitation next year, we're gonna do private live streaming, so if there are, clinicians that you know that may not be able to make it to the meeting, we will go to the top of the mountain. Yeah. Wi-Fi.
And then I do just a little teeny filtral adjustment here. There we go. Okay. So you hold pressure for me, just for a second. That's all set. And that's basically what I would do with, well, 2 syringes, so she's going to need 4 syringes. So I have the other 2 over there. Okay?
Okay, thank you, Victor.
What do you think, Vic? So, my experience with the, well,
Chin up just a little bit, yeah.
but any of them are at least tyndall effect at full concentration.
Tyndall effect at full concentration in what area? I'm sorry?
Anywhere where you're very superficial.
So in the areas where I go very superficially, so whether that's in the cheek creases or in very thin skin, I tend to use a different product. So I might use Volure or Volbella. I tend to not have so many issues with that. So occasionally if I see something in right at the corner of the mouth, there's thicker skin in that area, generally. So I can get relatively close, but not so close that I'm seeing my needle. And so that's where oftentimes you will see an issue in that particular case. But obviously, I haven't been super happy with Volbella, for example, in vertical lip lines, because either the patient's really old and they have really thick etched in lines, and then I haven't found, it looks good after I do it, but then like a few days later, the lines are still there. So I needed something a little firmer and thicker, so I used Volure. The place I've been happiest with Volure is the vertical cheek creases, and if the skin's too thin for that, that's where the Volbella works really nice through there. Volbella is really nice for lips, for someone who's got maybe a society matron who's just got thin lips and some wrinkles in her lips, and she doesn't really want it to show at all, it doesn't want any downtime. Then the Volbella is beautiful because there's really no downtime, there's hardly any swelling, and that's an ideal product. I think one thing I can't underestimate enough is the cleanliness of the skin with any of the Volbella products, especially around the mouth and the lips. And that's where I've sort of avoided some of the problems that I've seen with nodularity, is by keeping the skin clean. Because I've been referred problems with that. I had some initial problems, which I don't seem to have anymore, by really scrubbing the skin very clean. I had her wash her face, and I went over it like 4 times with alcohol pads, still got some makeup off. And so that's my advice, is just be super, super clean with your skin. Because even clean skin can have still some makeup on it.
Okay, we're gonna come.
The other side up underneath her eye, and what I did is I used one more. So here we finished up underneath her eyes, we finished up her lip, and I used one more syringe of the Juvederm, which was just to finish off her nasolabial fold. So what I did here was I did a deep depot injection with a retrograde injection, because I only inject retrograde basically for safety's sake. And so did a column basically here, and then did a little retrograde injection here, and then a tiny little injection right at her jawline here. Help straighten out along the jawline a little bit. She's pretty young. Turn your head a little bit for me, okay? To give her a little bit of definition here, and right along through here.
When you inject jawline, do you inject on bone or separate?
I do. I inject right on the bone, but then I pull back a little bit and create a bit of a column too. I don't come all the way up to the skin. Okay, I'm doing part of the Volux study right now, which is a little bit higher. It's a 25 hyaluronic acid, similar to Voluma. But we're injecting all along the jawline during part of that study. And so that's a big part of what we're doing is straightening out the pre-jowl and actually all the way back to the post-jowl. But in her, she just had a very soft flattening right through here. So filling here and here in her, she's young, 45 is young, so that's a sort of a peak age for her, but just helps soften it out and keeps her looking like she's in her 30s. So, but tell us a little bit about your experience. How was it?
Amazing. The dental blocks, I didn't feel anything, just a little mild pressure in some pinpoint spots in my eyes, but it was amazing.
Good. And you can see that she really has very little bruising, maybe one little teeny dot here, or maybe that was breakout, I'm not sure. But so I can expect we're going to get her some ice, and she's not too bad right now. She feels a little swollen, but she'll be more swollen probably under her eyes and, of course, her lips later on today. So that's it for Marie. Thank you for being our model today. She got a total of 4 syringes, 2 Juvederm, Ultra, XC, and 2 Voluma. Appreciate it. Thank you. All right.
You can see, so we did microfractional resurfacing, and the patterns that are on her face are tiny little dots of about 1.3 millimeters, and they're a little red today, and the pattern generator was square, so although they're kind of overlapping as we designed it, but they're going to turn dark, as we talked about, and then over probably 3 or 4 days from now, they'll start to come off. And then the skin will be pink, and over 6 months, we see improvements. But what we determined, because the severity of the lines is there, and you can see some etched lines here that traverse her vermilion border, and I can track them up into this area, is to do it, and then there's a little bit of a marionette line. So I'm going to show a completely different approach to the marionette lines that harkens back to the days of yore when we had collagen only. And the product of choice for me with this is Bellatero. And the nice thing about Bello, in my opinion, is it comes without lidocaine, so I can make it whatever I want. And I'll bring it, we've done a bunch of in-office studies with this longitudinally with all the HA fillers, and we find that if you bring their concentrations down to less than 10 milligrams per deciliter or less, that you can get them right next to the dermis and have zero Tyndall effect, which we've described as a physics phenomenon that was described very nicely earlier in the meeting. And so this is the stingy part, the beginning. The first couple of them sting, but so the treatment area for her is this, I often describe this as a transition between her cheek, which for everybody, she's slender and in good shape, so she doesn't have a lot of it, but it's going down and toward her lower lip, is sinking medially, inferiorly. And when we're trying to treat this, we're really softening the transition between this bump and this flat platform, and this flat platform is there because the skin is very closely adherent to the orbicularis muscle of the lip. And as we all have to explain to our patients, the lip starts here, the lower lip, and it ends here, and this part of the lip is the vermilion, and the rest of the lip is often described as the white lip. But what I'm doing is softening this transition between the cheek, and I'm doing really tiny little intradermal injections here. My sponge here. And this is just like, for those, maybe there's people that don't even remember it, but just like we did the old collagen product, So I'll be lifting a small wheel, basically, on the skin, and I find that this takes the very least amount of product and gets the very best results in my hand, because I am not going to be puffing up her entire lower lip by doing this and injecting large volumes of product. I am only treating the transition between her cheek mound here and the lower lip to make that transition, which I'm almost done, smooth, so she doesn't have a line of demarcation, which in effect lifts the corner of the lip up. And so the more I do, because I've got lidocaine in here, the number it is, the more comfortable it is for the patient. And if I need
More about how much lidocaine you put in.
so I like it 2 to 1, and it lasts at least 4 months at 2 to 1, and that way, and I don't charge people, but I really have from the very beginning not liked the idea of charging people. And some of our patients come in and ask, how much is it for a tube? And well, we're not selling tubes here. You're getting a service, so we describe this as by severity. It's either minimal, mild, moderate, or severe. And the treatment, there is a correlation, of course, with how much volume we're using, but I'm going for a correction. I'm not selling some volume of product. And whatever it takes, there is a correlation, and we market for inventory purposes, but it's really treatment by basically how long it takes for all practical purposes, the severity of the condition. So you can see a little bit of a blanch because I like to use Lido with Epi there. I think that helps to minimize any bruising. And then now that I've softened this sort of transition, because she's thin, I'm going to do a little bit in this arc so that the transition around the lip, because there's no filler in this is just soft tissue. I'm going to do it so that that transition is also smaller, and this is where I'll just go sub-Q. And in my experience, the people come in a couple times a year for this treatment. But I'm trying to really minimize the blowing up of the face thing, which I see, I think, way too commonly. I don't know if everybody watched the Academy Awards, but Sandra Bullock came out with basically 3 noses. She had a cheek, a nose, and a cheek, and they were all about the same projection. So, I mean, she's an attractive lady, but that's too much filler in my mind. We're not trying to make people blown up. We're trying to use the least amount to get the best effect. So that transition is softened in this corner. There's still a little tiny line, but these are intradermal injections only. And if I compare the 2 sides, can you lean your chin down just a little bit? And then, let's see, yeah, that's good. Just push your lower lip against your upper, just gently. Like a little tiny pout. Yeah, that's good. So this side of me, you can see it's softer. The depth of here, I don't know if it's 3D, it's hard to see on camera, but there's a substantial difference here, but it allows me to see that we can use another drop right in this area. So that's pretty straightforward and simple. I think I'm going to do the same thing on the other side of her lip. I'm not going to work on any more of that right now. And how would you grade that discomfort? Like the first one's a zinger, right?
Yeah, not terrible, but yeah, definitely feel it.
1 to 10?
Like 4 or 5.
4 or 5.
Mm-hmm.
Okay, so, and then did you do any, I don't know, did they put any numbing cream on you before we started? Okay, good. And I did an alcohol prep. I think the emphasis on sterile technique is understated. Victor, Dr. Lacombe mentioned this. This is a little sensitive to put alcohol on too because she was resurfaced yesterday, so I'm going to dab this. And she's got ointment on it that I took off earlier, just Aquaphor from the resurfacing. And then can you purse your lips for me? So I can see the lines that are created with the pursing. Are those visible on camera? There's one right here and there's one right here. And this first one's a real zinger. I'm going to just tell the patient that. But I'm going to lift the line up only. This is truly intradermal. You see the wheel that I created there? And I'm going to do this with little drops of dilute HA, and I'm not going to make her whole upper lip plump. And I've seen lots of demos of doctors doing this, what I call the poke and plump technique, where they put in a needle and really blow the entire upper lip up, and it does give you a effacement of lines, but it does it at the expense of making the upper lip look sort of simian, I guess, for lack of a better description. And so the least amount we can do to efface these lines, purse again for me, is the best result, I think, and then relax. So I'm just finding that little line only. And it's a tricky technique, but it's not new. Arnold Klein, for those derms that remember Arnie when he was a big teacher of injectable fillers, which at the time were only collagen, talked about the art of the intradermal injection, which that was so important with collagen because it almost went away and it would be gone in 2 weeks if you weren't intradermal. But with the HA fillers, there's really no duration performance relationship between being subdermal and being intradermal. So the real value for intradermal injections is, for me, just the easy effacement of lines with small volumes of product. So, and then she's got some volume loss in her lip border, and she's got nice cosmetic tattooing here, so she's a great candidate to do a little bit of vermilion enhancement. And I've gone through all of them. I like Vobella. It doesn't have a lot of swelling. Velour a little bit more, lasts a long time, nasolabial fold, but I've sort of gone full circle and landed back at Restylane L, which because of its G prime stiffness and the consistency of delivery, is for me border choice one. But they're all good. I don't really. I mean, if a patient comes in with a preference, that's great. And I think this was shown before, but I'm going to do there's a potential space here. It's a little stingy, but it should be less. And I'm looking for, if I can get it, I can track it all the way along that vermilion border without having to really even advance the needle. And all I'm trying to do is efface her lines. She doesn't want big plump lips. She just wants to get rid of her lip lines. So you can see that tracking right past her Cupid's bow, and the lip border is nicely enhanced there, and I'll soften it a little bit further, but her lip lines are pretty close to being gone here now. I would also just recommend avoiding the tubercle. There was a nice study on Lip Beauty that showed that the tubercle is between the two filtra, by the way. Can you grab that? You can stand here. Just hold that for me. Tubercle is in between the two filtra, and augmentation of the tubercle is unattractive. So you want to avoid that. We want to treat the lateral lobule of the lip. So from the filtra out, if you're doing lots of volume or you're doing tiny amounts like I just did, to efface these little fine lines on her lip border. And I need a little more bellow in this line too.
Yes, a question about whether you think it's useful for horizontal necklines, I think some people call them necklace lines.
Yes, this is a good way to do those. And you can track them out and make them go away pretty much with this technique, because the only way to treat those is intradermally. They're dermal lines. They're not going to be treated by going underneath, I don't think, unless you put a large volume of a hydrophilic filler in. It's pretty hard to lift the necklace lines up.
Is that your preferred then for that? That's the question about.
Preferred for
necklace lines.
Oh, my preferred is to do resurfacing, fractional resurfacing on them. And then if they wanted to treat them, yes, I would definitely do what I'm doing right here with Bellatero, yes. But you can use other ones. That's why I was asking, my experience with it
in order is the highest frequency of Tyndall, even when you dilute it, is with the original Juvederm product, and it's less for sure with the Vicross products. And then Restylane, I think to me, it's better. Silk has more swelling associated with it because there's more surface area. There's smaller little particles, so there's more places for the water to absorb. And Resty Lift would be fine too, but it's bigger. I mean, if everybody doesn't know this, like the analogy that's given by the HA scientist is Resty Lift is like you had a bunch of Jello and you chopped it up and you put it in a colander, a sieve, and you shook it, and the smaller particles would fall through, and the big ones at the top are the lift. And then if you had a smaller hold colander next to it, and you chopped it up and shook it a little bit, the medium size or the Resty L, and what's down at the bottom are the silk. And so when you have a lot of tiny particles or smaller ones, there's just more surface area exposed, and they're all hydrophilic, so they're grabbing more water, which is why you see more lip swelling when you do Resty Silk. And some people like that bee stung look. It happens with Juvederm XC too, the Ultra and Ultra Plus. So the Vicross products still have more water absorption than the Restylane products, but it's certainly less than the original Juvederm product by far. And then there's the longevity. The velour, and we were in the study with velour, I mean, it lasted 18 months in nasolabial folds. That's a big deal. And the Vobella is an attempt to lower the concentration of the HA, but it's just not quite enough. So we see Tyndall intradermal injections with Vobella. I think Victor kind of got to this too. You still have a little bit of Tyndall effect. So it's not perfect unless you put a little more water in it even. The 10 milligrams per deciliter seems to be the cutoff, where you just, with most of them, you can put them as close to the dermal surface as you want, and you're not going to see any Tyndall, which is really common, by the way. I see Tyndall all the time. People think they come in and they say, the last time I was treated was 6 months ago, and I'm still bruised. And you look at it, and that's not a bruise. Had some hyaluronidase, and they think you're like a witch doctor. You're a magician. You give them a little dilute hyaluronidase. I dilute the hyaluronidase, by the way, which I strongly recommend. If you just want to get Tyndall, you put 2 to 1 of lidocaine with the hyaluronidase and do really small drops, because you really just want the very superficial HA to be gone. You want the rest of it to stay if you can, and you can fine tune it a little bit more than just taking it right out of the syringe. And then we're going to take a break, right, Jim? Or we're going to break
right after this.
Okay, yeah. So I'm going to do our other side. We can come back in a second.
After this one. So with Chrissy, you can see.
Her lower lip is really pretty good. She just had a couple lines here and one of them's a little hyperpigmented, so that's probably inflammatory. But I lifted those 2 up, and then the corner of the mouth is lifted, and I think she's pretty much done with this area. And then with the resurfacing, she should really see a nice improvement by the end of the summer in the whole perioral area. And then we're done. I'm going to do a little bit in these two lines here while you guys are having a cup of coffee, and then a little bit in this line, this fine line right here. This is bellow. It's my it's my own concoction, because this is bellow 2-to-1, so it'd be about 11 milligrams per deciliter. I think bellow you can cheat a little bit higher than it's the one that has the least amount of tyndall, at least in my experience. So I told you, everybody, I think most of these products, once you're below 10 milligrams per deciliter, that tyndall effect is a really reflective phenomenon, and it pretty much goes away below 10 milligrams per deciliter for most of them. Even if you saw how superficial those injections were. I can demonstrate this as demonstrate that again, but I'm just lifting a wheel. This is just like we did the original collagen product. I would typically be coming from below, but for purposes of videography here, it's a little easier to see. I'm turning the bevel down and I cant the needle just a little bit. I don't know if you can see that. But those are, personal preferences. I'm not sure they're that important, but it keeps the syringe off of the plane of the patient's face. So the syringe angle to the patient's face, the needle is almost parallel to the skin here, but the syringe is at about a 45-degree angle to the patient's skin surface, which is why I bend that needle just a little bit. So there's that wheel, and that you can overcorrect a little bit with this wheel technique. It's like the old collagen technique, but because some of this is local anesthesia. But I can lift those lines up and they're gone. So that's what I like to see, gone lines. People like to see this too, by the way. When they leave the office and they're like, there was a line and now there's no line. That's a good thing. So I think that's good. You guys can take a break. Are you going to do more, Jim?
No.
Yeah.
So we have this nice young lady here who's in pretty good shape. She's actually 59 years old. She's very athletic and has some expression lines that she wants to take care of. She is asking for something that is very long lasting. So one of the products we're going to show you today is the only permanent filler or long-lasting filler that's approved in the United States, and that is called Bellafill. And so Bellafill is a mixture of collagen, bovine origin, as well as polymethyl methacrylate. And these are smooth particles, about 30 microns in size, and manufactured in Southern California down in San Diego. So Bellafill is from Suniva Medical. They have a lot of good data, 5-year long-term safety data, totally different from the issues that we were having with the original bovine collagen in the Zyderm and Zyplast days. So patients typically, we just make sure with a skin test that they're not sensitive to the product. And the concept is the collagen will go away after about 4 months, and the small polymethyl methacrylate particles stay behind, and the body makes collagen around them. So Suniva Medical is exhibiting here at our meeting. If you want to gather some of the long-term data, it's there. It turns out that the risk of nodularity is comparable to other types of products that are out there. The main issue is that because it is a permanent product, if you do get a problem or a nodule with it, you will have to deal with it. But the incidence of that is like less than 1% over the long term. So how do you inject it? It basically comes with a 26 gauge needle. It has to be a little bit larger than your typical needle. And we're going to inject it similar to the way we used to do
collagen or Zyderm. We don't want to overcorrect. You just want to take this product and use it to full correction. It is approved for not only the use into nasolabial lines, but also for acne scars and mid-face volume restoration. The product does contain a little bit of lidocaine. So technically, it's kind of a linear threading technique that we're going to do here. So we'll have our patients smile for us, and so you can relax there. So she's had some fat transfers in the past that we've used to do for some of the deeper volume restoration. So we're really using the Belafil for these etched lines that we want to get some impact for. And so she's had some topical anesthetic, and again, we cleanse the skin very thoroughly. We'll do that again right before. So alcohol is good. Hibiclens is also good. Dr. Bitter yesterday mentioned hypochlorous acid, which is also a wonderful disinfectant for the skin. And so, all these long-term fillers, whether we're talking about the use of Sculptra or Voluma or Belafil here, we really have to keep in mind that this should be as clean a procedure as possible with full sterility. And if a patient has, acne breakouts or something like that, we obviously won't do the treatment at that time. So again, the 26 needle here, we come and just distract the skin here and little poke here, sorry. And we're just in that immediate subdermal plane where you can just kind of see where the needle is. And it's just small little linear threading. And we'll kind of move from lateral to medial and just take advantage of the anesthetic effect there. And so for patients who are looking for that longer term situation, we have a lot of patients who don't like to come in for repeat treatments, and a lot of our male patients also like this product a lot because it does have that duration of effect that's not comparable to other types of products there. And so we're just going to march along here. So we're basically just right underneath the line. Sometimes we will pass the needle back and forth a little bit just to do a little bit of minor subcision there. Get these little dermal attachments. And we're just effacing the line to full correction. We're not going to overcorrect through here. Belafil shouldn't be used in superficial areas around the orbit or within the lips because it can be palpable and you can feel it. It is different than the previous products that came from Europe, which were known as Articol, and in Canada. But the Belafil product has been available now for over 7 years in the United States and has a good safety record. So in my previous 5 years of use of the product, I can say that we haven't had any nodule formation with it, but there are some things in the literature that have some difficult historical perspective on some sort of methyl methacrylate that obviously has produced some problems. And a lot of these studies have come from overseas where there have been different formulations of methyl methacrylate that can be very inflammatory in the skin. That being said, all the long-term marketing surveillance that the FDA requires, I think that Belafil is performing very well. So we can see that immediate type of effacement of the area. We'll just continue up here for the last little part. And so its use is very cost-effective over the long term, especially in a patient who has just moderate to severe nasolabial creases and marionette lines. Yeah, so we're just right in the deep dermis, just immediately in the deep dermal plane. You can try and put this in intradermally. You can get some blanching, but we're sometimes it's hard to get the needle right into the dermis. And we'll just come up here a little bit more. So with one syringe, I'm going to be able to treat both areas here, both sides. This product is more of a premium product, so it averages about $1,000 for a syringe for our patients, and so it is more of a premium product. You'll have to kind of explain that, why this product is more costly, and that has to do with its duration of effect and, of course, the cost of the materials to your office as well. So I think, it's not that what percentage of patients, get Bellafill. It's still only about maybe 5 to 7% of our patients. There is some hesitation to using something that is permanent, and we understand that, and it's just a discussion that you have to have with your patient and make sure that that's something that they want. But I think it's important that, I think as patients get aware that there is a permanent filler out there, you'll have to have that discussion whether you choose to use it or not. There's pluses and minuses to it, but I think that it has a good safety record. As I was saying, the degradation of the carrier is pretty much gone by about 4 months. I'd say that probably 80% of it is gone by 3 months, similar to what we would see with regular collagen. The collagen buildup process, once those beads kind of get more exposed from the surrounding collagen, any kind of contact, that reactive process with the fibrosis will start. And then we see the peak effects going till about 6 months. So if you just do like one syringe like we're doing right now, and we wanted to see kind of the full effect for the patient before we decide to do any more, you can wait 6 months. But as I was saying, sometimes we'll have the patient come in at 4 months just to see which other areas we might be feathering in or treating. So you definitely want to go a slower approach when you have a product that's going to be permanent. Yeah.
Okay, so we're talking about hand rejuvenation today, or this afternoon, and we have a very lovely patient here who looks much more youthful than she told me she was, and I'm not going to reveal her age, of course. But can we see her hands here? Yes, okay. So one of the things we do when we look at her hands, let's see, here we go, is we see a variety of things. Sometimes we see texture with skin and sun damage. Sometimes we see pigmentation and brown spots. I don't know if we can see this right here and over here. And then we also see contour. And so there are a variety of things that can be done. We can use lasers to, whether it's an IPL or a pigment type laser, to remove some of the pigmentation. I tend not to do a lot of resurfacing, but it is possible to do some very light sort of fractionated type resurfacing for some of the pigment, the texture. One of the things that can be the most dramatic and relatively straightforward is to do some fill for volume. In her case, she's got a little bit of volume loss and some boniness to her hand here. And we can see some larger veins here, and we can see some of the tendons which are poking through that make her hands look a little thinner and a little aged relative to what we might like them to look like. And so today we have some Radiesse, and they've been so kind as to take the 1.5 cc syringe and actually dilute it down for me, 1-to-1 with some lidocaine. And so what I tend to like to do is to actually start down here by the knuckles and make a little tiny insertion point and inject between the tendons and, of course, skipping around between the veins. There is a technique which I tend not to like to use where one makes a large bolus in 3 separate little spots in through here and then just massage it around a little bit. I think I might need a little bit of moisturizer to massage it. Something like that, yeah. And so I still do massage it around, but I tend to not like to just put a big ball in and massage. It just doesn't seem very anatomic to me. And there have been some cases in places where there have been some lumps and nodularity, and I just like to inject it where it kind of needs to go. That's me. So this is why we're going to watch it this way today. All right, so she has had some numbing cream on here. I tend to sometimes put a little tiny bit of bolus of like a little tiny bit of lidocaine here in between each knuckle, and sometimes over in through here, but that's not what we're doing today. Okay, so you'll feel a little prick, and there's a little bit of lidocaine, of course, mixed in through here, and this is how we. I wiped it with alcohol. Okay, because of course sterility, as we talked about, is very important. So again, I'm injecting here, and then I'm pulling back as I inject, and I'm not going really close to the dermis. I'm going in that space between the dermis and the interosseous muscles here. And then I tend to hold and put pressure and do a little massaging around. And then I move further forward. I don't have the best lighting here, but I'm really trying to avoid the big old veins. It's not the end of the world, and I usually tell people they will get a little bit of bruising, so you can see where my needle is here, but again, I'm deeper, so we're not going to touch the dermis, and I'm in this easy, very flowing area where we're away from the deeper muscular structures, and it's a very sort of no pressure whatsoever, no tension. Injection just flows very nicely and very easily. I'm going to pop over here next to it and go into the next interosseous space, or intertendinous space. There's also a bone in here too, but okay. How you doing? Okay, so each time I come out, I just hold a little pressure here. I'm going to slide over here. I'm a big proponent of holding pressure. I think that that's something that can prevent us from getting as large a bruise as we might otherwise.
You didn't dilute the radius at all, correct?
I'm sorry, they did dilute the radius, yeah. 1-to-1 with lidocaine.
Say that again, I'm sorry.
1-to-1.
So that gives you 3 cc's of total volume.
Yes, per syringe. It's not necessary to do that. In fact, I oftentimes use hyaluronic acid as well, and when I use a hyaluronic acid, I do not dilute. I typically use at least 2 cc's per hand. I'm using a little bit more here because I know the lidocaine is going to go away. And I just liked it to flow a little bit better because of the more particulate sort of calcium hydroxyapatite nature of the radius.
And of course, there's integral lidocaine in the radius plus.
There is. I just, because of the texture, I like it to spread as easily as possible.
So I think there's 2 products that have indications for the hands, Radius and Restylane, is that correct?
I think
Restylane Lift has an indication as well.
Restylane.
Okay, this seems to be plugged here. It's good. I'm going to finish off over here by the pinky.
What do you tell your patients as far as duration goes, Dr.?
Generally, I tell them about 9 months to a year, and sometimes it's really only 6 months, depending on how active it is and what their metabolism is. And again, I'm skipping in between the vessels here.
I noticed Carolyn has the ring on. They typically get, what would you tell them about the swelling and as far as wearing rings for the first few days?
It depends upon how tight or loose the ring is, but typically hasn't been too big of a problem.
Yeah, you have patients who go to the gym and start working out like right after they can get a bit of swelling, so it is advisable.
Yeah, we do tell them not to do a lot of heavy exercise with their hands and to kind of keep it light activity-wise. They can definitely have them ice it for the next couple of days or so because they will get some swelling afterwards.
Some people do compression afterwards, do you?
I have them hold it. So for example, when I'm by myself in a room with a patient, I'll have her take this and then put her hand on top of it as we work on the next one.
But afterwards, like that?
Oh yeah, afterwards. I definitely have them ice it. I don't have them wrap it though.
Okay.
No.
I
Okay.
tell your patients just sit on their hands, you know, they can do that.
Okay.
When
So
they're done.
then, well, I don't have, oh, here's a little Aquaphor. Okay. So then, it's actually relatively smooth because I'm massaging as we've been going along. But then I would take some of this, and I would massage it. Generally, this is very important because I've seen some videos where they've done, you know, in the rest and lift trainings, where they just put a couple big boluses and they just massage the heck out of it like that. I've been massaging it as we've gone along and injecting it as we've gone along. And then let's see the two side by side. Okay, and put your hands out like this. Okay, so we can definitely see we took basically 3 to 4 syringe cc's there because one of them sort of plugged up on me there. Have really been able to plump up her hands now again like this, okay, and really smooth out in between her tendons and her fingers. I don't know how well we can see that, but it looks a lot smoother in through there and not lumpy at all at this point. Questions about that? Anybody else do it that way, or do people do the big bolusy way?
What total volume did you use?
So I used 2 full syringes, and then I used about 0.6. So it was basically 3.5, almost 4 cc's, but I know that half of that is basically lidocaine. Okay. So it really ends up being about 2 cc's basically of the actual product.
And then when you do your pulse light right here at the same time after you've done that?
Yeah, so if we actually see some bruising that's coming up, like I see a little bit right here, I would go over that. So I use a 532 basically green light laser, so I would go over that and treat it for bruising, or bring them in the next day if we actually get some active bruising.
Okay.
All right.
We'll let you continue on and finish that off, and we'll go to camera here on the right where we'll check.
So we basically use about the same volume. Let me put my microphone on. Okay, we use basically the same volume on the other side, and seemed like that was maybe a little more hollow on the side, and we put a little bit more over on her right hand because she's right-handed. But I told her she'd probably give me a little bit sore tomorrow. She said she was going to be shoveling a little bit of snow maybe off her car. But again, you know, we're going to have her hold pressure because we're showing it here now, but she's not holding pressure like she did on the other side. But she was surprised at how quick the whole process was, but it doesn't take very long because there's no resistance in any of the planes. I had her go open her hand, like open your hand for us, okay, and then move it back and forth so you can see places you might have missed in that process. But it's relatively straightforward, and that's why I kind of like doing it with the multiple poke process. I like only doing retrograde injections because there are a lot of blood vessels you want to be injecting into one of those blood vessels. So it makes it safer, it makes it relatively easy. She's relatively not very bruised considering how much volume we did in her and how thin her skin is. And again, we will have her just hold a little pressure on her hands here.
Her hands, so she's
And
not going anywhere.
there you go. And she's going to be doing some other injections now. So here we go.
Our patient here also had the microneedle subdermal radiofrequency treatment as opposed to an ablative laser. So we can, she had her entire neck done, and so this just shows, we can show a little bit of erythema present, but all the injury is really subdermal. We also did around her cheeks and her peri-orbital area. So that's the difference between kind of an ablative treatment, and this is kind of a sub-ablative treatment because all the energy is beneath the epidermis. What we're going to be showing today is the Restylane Lift product, which, as Dr. Moss said, is the largest particle size. I don't know if anybody's ever opened a Restylane box recently and grabbed the package insert, and you open up the package insert, and it's got all this paper in it. And it's completely blank. Okay? And the reason it's completely blank is because they say, the instructions are on the website or call the number. So for all of those, who are part of the new Green Deal, this is the first thing you should tackle instead of, other things. So there's a lot of extra paper to take home for your kids to draw on. Okay. So as I mentioned, we're going to be using some of the Restylane product. Now we're going to use a 25 gauge cannula. And these cannulas are really nice because they're marked. They have the little red dot that tells you where the port is. And the new thing is this little introducer now that comes with the cannula. And this is designed to make a little puncture in the skin, and it's got like a little trench so that when you put the cannula in, you just lay it here and it'll kind of guide you into the hole. Now that's really important even if you're using like a smaller 27 cannula or whatnot. So we're going to take this and just puncture kind of just in through the dermis here. And then I don't have to look that close, but I can just take this cannula, put it in that little trench and stick it through the skin, take this out, and I know that I'm in, okay? So that's a neat little trick that has come about from Softfill. So we're gonna use this for the lips. So yeah, there's less bruising with cannulas, no doubt. So we're gonna take this and just pass it into the submucosal plane here. And then I'm gonna twist my thing, and I know exactly where the port is. In this case, if you want to inject with the port towards the surface of the skin, you keep the dot up. If you want it deep, turn it the other way. So I don't think it really matters, but for this demonstration, I'm going to have the port up. And we've got our nice little Restylane Lift product, and we're just going to slowly come through here and pass it through. So cannulas have a big advantage for your your high maintenance patients that we had that wonderful talk on this morning, and they don't want to have any bruising, or they're coming to you and they have a wedding over the weekend and it's like, please don't bruise me. It's worth it to take a cannula and utilize it. So all the HA products inject very nicely through here. We're going to just do a few little multiple tunnels through here, and then I'm going to come over on the other side and do that. But with that, we just put in about close to half a cc of the product. There's no, bleeding there. We can massage it and everything. So I'll come over to the other side.
Jim, what size cannula is that again?
Okay, this one I'm using a 25 gauge cannula. You could use a 27, but I'm using the larger particle product. I think you can also get a the lift through the 27, no problem. Let me come around to the other side. get a close-up of this cannula introducer here so people can see. So I'm going to bring it a little closer here. So like I said, it's got perfect, this little trench, so you just put the cannula through here and be able to slide it right in. So we're going to be approaching the lip, so we want to be a little further away, just out here, just past the lateral commissure. A little poke here, just in through the skin. This doesn't have to go, you just want this through the dermis here, and like I said, just take it right here. It'll get you right in, slide it right out, and then we can proceed.
Can you talk a little bit about your choice of using lift in the lips?
I'm sorry, say that again?
Talk about your choice of filler, the lift for the lips, and why you chose that.
Yeah, so in this case, we're using an HA. You know, the difference between, you know, this Restylane, she wants a little bit more structure for the lip. It is true, I think the Restylane products a little bit more firmer than perhaps maybe the Juvederm. If somebody, you know, is maybe coming in for their first time, they want a very conservative type of approach. Here we're looking for a little bit more volume, and I like using lift in the deeper part, you know, of the lip. As Dr. Moss said, sometimes the smaller particle product, such as the silk, does produce more swelling. And so, you know, we'll use that. I use that less compared to the regular Restylane and the lift products. But you can see right where our cannula is here. And we're just going to, again, find that little red dot and know right where I am. And it's just like playing the violin here. Just go in and out here a little bit. And again, you know, with this, you're really not 100% guaranteed, but you're well on your way to having, you know, less chance of any kind of bruising. Open your mouth here just a little bit. And the cannulas, you know, don't hurt that much. Once you get it through there, you can, you know, manipulate it and put it right in and make it a little bit easier. So there's that one. Okay, so now her bottom lip in the beginning was a little bit less volume when we talked about the ratio of 1/3, 2/3. So her bottom lip was a little bit, you know, under-corrected. So this is going to bring us back to a little bit more of a nice relationship with having that lower lip volume up there. And so that's the demonstration with that particular part. We can go ahead and take a break. We're going to just finish up these patients, come right back. So about 15 minutes you can visit with the vendors out front, grab a coffee, and come back in. Any questions before we go to break? Oh, maybe we'll come back and look. We can switch back to the final result there with Dr. Moss.
Yeah,
Okay, well, I'm honored to again be invited. One of the values of, one of the tremendous teaching values really, I think, of the live demonstrations, the way that CSFPS does it, is that we really get an opportunity to see a lot of different faculty demonstrating different techniques. And as you saw with the fillers, there's a lot of different ways to do things. So I'll demonstrate my technique with our celebrity model here, who Carolyn expressed to me that she would love to see a little more volume in her face, would love to see the area around the mouth just look nicer, and that doesn't like a witchy chin. And let's see, I think we got most of those. And then whatever lines that are visible that she can see, she'd love to see those look softer. You've seen a lot of different techniques. I've watched all the injections being done. You're going to really, I think there's, other than cosmetic surgery, there's no other area where you're more artful than working with fillers. So the take-home messages are that I want to share with you are the following. Actually, if you want to hand me the laser sim there, okay? So the laser sim here, the bottle. So one is hypochlorous acid. I don't use alcohol anymore at all. So I've got a bunch of leftover alcohol pads and I use them to wipe the floor, down spots on the floor. And I don't use alcohol on people's skin at all. So I use diluted, stabilized hypochlorous acid. I prep the face with it. I use it throughout the procedure. You can spray this in the eyes, in the nose, in the mouth, on the lips. I've already sprayed it on my hands, so I've prepped my hands with it. You need to know, you really should know about this product. Second is that one of the presentations that Dr. Malik did earlier today, talking about beauty and concepts of beauty, and I think she had one slide with all these different faces, women's faces, all young, different ethnicities, but they were all very attractive faces. And even though they were all different ethnicities, the one common feature every face had, and I invite, and I just suggest, when you look at faces, look for this, is, if you turn a little bit to the side, is an attractive angle of the jaw, an attractive chin, and an attractive malar cheek. And you can tell if somebody's attractive even if you hide the lips, the nose, and the eyes. And they turn to the side, you only see the side of the face. You can tell an attractive face by those three features. And with fillers, you can create a more attractive face for almost anybody, no matter what age they are, by knowing how to do filler in those three areas. Second, so there's three things really key to being successful with fillers. I'll demonstrate some of that. One is knowing how to revolumize the face so that those three areas look attractive, not overdone and not over full and not unnatural. Second is being artful at creating attractive looking lips that look natural. And just be good at making lips look nice. There should never be anybody walking around with lips that don't look anything like what God or nature would make. Nobody should have bad looking lips. It's not the filler and it's not the patient. It's the artist doing it. And the third is be very good at filling in lines. If you're good at those three things with injections, you'll be very successful with injections in your patients. And I agree completely with Dr. Miles. I learned also from Dr. Arnie Klein. I was a student of his back in the mid-'80s, where we only had Zyderm collagen, and we basically filled lines in and did lips. We didn't make people's faces look overinflated. So I've been injecting filler for over 30 years. So I'll show you I'm going to use the Galderma products. I'm going to use 3 different Galderma products. So I use Restylane Define in areas where I'd like structure. So I'd like to create a little bit of structure, and I know I want to have it hold up. I'll use Restylane Refine, where I want a little softer product. That'll be mostly at the corners of her mouth. And then I'll use Restylane to outline her vermilion border on her lip. And it just creates a nicer, more attractive looking lip. And then filling lines in. So I first need to prep her face with the hypochlorous acid. Okay, so this is sprayed with, I need a bunch of that there, okay? And then she has numbing cream on her face, and she put it on, and I'm gonna show something to you, because you need to get everything off the face and clean it. I completely agree with the points that have been made multiple times this afternoon. So actually, I'll take the bottle of that if you want to give it to me, okay? And then give me another one right here. So my assistant just saturates this. We'll saturate it with hypochlorous acid. It comes in an industrial size. And I wipe down the entire face. I don't have any issues with biofilm ever forming. I've been doing this for the last 3 years. I don't use anything else to prep the skin before fillers or before, I'll prep her entire face. I'll do it 3 times. So we'll prep it 3 times. I need another one right there. So if you want to give me, so I'll need a few more of those. So I prep her face 3 times until the gauze is clear and there isn't any makeup, there isn't any sunblock, there isn't any leftover moisturizer on it. And then I will use this product throughout the procedure. I brought it myself. I don't travel without it because I spray it in my nose on the airplane to not get colds. It works. If you're sitting next to somebody who's coughing, you spray this in your nose. Small size like that, you can travel with it on the airplane. Okay? All right, you're doing great. Okay, so I start by first creating some structure, and I like to start on the top and work down. Okay, so I'm going to spray a little extra here. I'm almost out of it, which is a drag. Okay. There we go. And turn that way from me here. You can spray this in the eyes. So just saturate. And then if we give her a couple extra gauze, so Carolyn can just catch whatever runs down her neck there. All right? then give me a dry one, and I'm going to set this. I'll either have you do that, and then I'll take the Restylane Define. So where I like to start is the cheek. I'm a needle injector. It's largely how I learned. If you spray some hypochlorous acid on here, and then I like to start by just restoring this. And I let the patient look in the mirror, and I'll do that. And I'll just say, well, that looks more attractive. So I'll start right there. Now she...
On shoulder, you're subcutaneous.
Okay, I am in the mid-fat. And I inject slow. Other take-homes are, I think it's better to undertreat patients. And I would rather have somebody come back and do a little bit of touch-up than overfill a face or overfill lips. I always look at the other side. When I'm doing, adding structural volume like this, I have the patient sitting up like this, because you really kind of need to see how they look. And I just add the amount that, looking at it and eyeballing it, looks attractive. Now she had, which procedure was demonstrated yesterday? Clear and Brilliant. And she probably has a little edema from that, which is going to throw things off a little bit. Typically, I'm injecting about 0.1, and then I just look at the cheek. I look to make the high point here, and you can look and see she has this depressed area. So I compare the two sides. I have used about 0.15. So if you spray some more on here, I'm going to point out, I keep a saturated gauze with hypochlorous acid on it, and I wipe. So when you touch it with your glove, you contaminate it. So I always wipe before I re-inject. And then I'll create just a little bit more where I know I want to create, add a little bit of volume on our cheek there. I always look at how much I inject to get an idea.
So why define and not lift?
Well, this is the product that they gave me for one.
Okay.
Great. That's a very good question. I use either Voluma, Lift, or Define in this area. So you can use a variety of products. Part of it turns out to be what you like. Part of it turns out to be what the patient had before that they really liked. Okay, and then now I would love to have also used Sculptra for her in her cheeks, because she would have been able to get a nice volumization of sort of the mid-cheek area. And not Sculptra alone, but Sculptra with an HA, with one of the HAs. And she would have had a really nice volumization and of the cheek, and also the quality of the skin would look better with that, with using the Sculptra. Okay, so let me have you lift up a little bit like that. Okay, great, and then turn a little side. Are you doing okay? Mm-hmm. And then I shape, with a gauze saturated with hypochlorous acid. This weave in the gauze is looser than I like. And I don't call this massage, I call it shaping. So I'll shape the product until it looks totally smooth to me, and the contour looks exactly the way that I like it to look, and I'll compare it to the other side. And then I'll go now to the angle of the jaw. Turn now towards your right, you're doing great. Okay, maybe I'll just shift a little closer towards me, and then like that. Okay, is that still good on the camera? I want to make sure I'm not getting in the way. So I'm re-prepping this area, I'm re-wiping it. And then I put my fingers on the inferior angle of the jaw, and then the very lateral angle of the jaw. Bite down. So I have a bite down. I feel the masseter muscle. I'll re-prep, spray a little more. So I'll re-prep the area that I just touched, then relax. And I've been doing this for the last 2 years, and patients, I'll use typically Voluma, so relax. Okay, and I go all the way to bone. So I'm on bone now. And then I'll inject very slow. And what this does, especially when you inject a little bit of product, anywhere between 0.3, you doing okay? Is that all right?
That's all right.
Okay, uncomfortable?
Oh,
Just a little bit? Okay. So it's surprisingly usually not particularly uncomfortable. I'll inject 0.3 to 0.5 and then shape it, just like a sculptor would. Okay. I'm just injecting very slowly there. Doing okay? Mm-hmm. All right?
So Patrick, why do you inject on the bone there as opposed to between the
carotid and skin?
So I, one, feel comfortable injecting on bone because it's a plain easy to find.
Sure.
Two, so when you go in with a needle and you go right through the relaxed masseter and you can hit bone. Two is that when you inject below the muscle, it forces the muscle out a little bit and it creates actually a nicer contour. And also, if you place the product in the right place underneath the masseter, when the masseter moves and people bite down, you don't see a bulge of product. And because the product's sitting underneath the masseter. And then I shape it. So what this does is it defines the angle of the jaw better. It lengthens the mandible, which shrinks on almost everybody with age. So when the mandible lengthens like that, it looks more attractive. And look at all those attractive faces. Look at every model that you see in a magazine. They all have a very beautifully defined masseter, whether it's a man or a woman. It's just a feature that looks really nice. And most of us, we just lose bony volume. I'm going to do a little bit more. I haven't used very much here. So spray a little bit more for me there. Great, okay. We just saturate faces with the hypochlorous acid. Okay, and we'll go right there. Relax a little bit. Perfect. Okay, and then I'll just inject. That's okay? Feels okay? All right, you're doing great. So in this case, I've only used really probably 0.2 of the product. Which needle did you put on?
31.
Oh, 31. No, I don't want a 31. Okay, it's injecting way slower than I need. So actually, if you give me the one that has, that it comes with, that'll be a little bit better. And then her chin, when I line up the chin, it already comes out. I'll let you change that for me there. It already comes forward a little bit. She doesn't want it really projecting more forward. But if you look straight on, she has asymmetry on her chin. And the right chin is more pronounced than the left, and she's just, it is indented there. So you can project a chin forward, which looks nice on people that need forward projection of the chin, and you assess that looking laterally, but she doesn't need forward projection of her chin. She just needs it to look symmetrical by putting it on this inferior border of the mandible, okay? That will be much better. So, and then a little more hypochlorous acid there. And those are the three areas that I'll go. And then I'll add in the mid-cheek if someone needs it in the mid-cheek. Are you ready? Okay, so a little relax. Oh, you're doing great. And I know exactly where I am. I can inject the product. I was thinking it was coming out rather slowly, and I didn't notice you put a 31 gauge on. So I do use 32 gauge, but that's for the fine line work. So be able to define and show that better. Okay? And turn a little bit to the side there. And then I shape it. You can feel the product and you shape it with your fingers, just like a sculptor would, in shaping that product. So I'll use Voluma for that, Restylane Define or Restylane Lift, and then spray some more of that for me here.
So we're going to let you finish that side of the face, and we're going to come back here in just a moment. So.
side of her face. And used Restylane Define, again, in the below the dermis, really mid-subcutaneous here, shaped it, and then at the angle of her jaw. And when I wasn't on camera, I used a little bit of the Restylane Define in the slight divot that she had on the left part of her mandible. I didn't put any there. I also put Restylane Refine on the right commissure. I'm using alcohol because I ran out of my hypochlorous acid, so it's what I don't normally do.
We can see that lifting part on that commissure side from what you did. So can you just say how much product you put on that?
Okay, so I use the Restylane Refine. I do a bent needle technique that Dr. Moss showed. Again, something that I think very few people know how to do. So I take I've bent it already, but I typically bend it about 45 degrees. I bend it usually always with the gauze saturated with hypochlorous acid. Then my staff sprays the needle and the syringe again. So we just spray the syringe with hypochlorous acid. A slide was shown earlier today where it kills almost everything in 60 seconds except for your patient. And so the technique then I use a 45, so the 30 gauge needle bent at 45 degrees. This is the Restylane Refine. And I like to enter down here, the tip of the needle now up at the edge of the vermilion border. And I just do a retrograde injection and watch the volume of the product fill up. The amount I used on the other side was about 0.1. She doesn't not need a lot of volume everywhere, actually. Little bits here and there.
By the way.
Okay, and then I take the gauze, again, usually saturated with hypochlorous acid. Open your mouth a little bit. Okay, so when I do that, can you see the product? Okay, you never want to leave it that way. So you shape it. So here I'll shape it. I usually shape it when it's the commissure in a superior direction like that. Okay, and then open again. And you can see the product is much less visible. And I'll even shape it this way. So I'll shape it like that, and I won't re-inject this until I prep it again. And it normally would be with a hypochlorous acid. Okay, relax. And then I've got an alcohol prep. I'll re-prep that area that I've just touched. And I honestly believe that biofilm is typically bacteria that's a round product, and the bacteria grows gradually over a period of months, and then people develop either immune reaction or to the product being there, and all of a sudden people have these nodules that develop. I don't have that happen, at least not don't have that happen with the hypochlorous acid I've been using.
I'll knock on some wood for you.
Now I'm using alcohol, so great, thank you. Okay, then I'm gonna straighten the needle out, and I normally would spray it. I'm so used to having it sprayed, I'm holding like that, so I don't have that. And then I'm gonna put just a little bit of Restylane Refine on top of where I had the Restylane Define, so I can get a little bit more lift. Now I find that this is a really common area where people get a depression as they get to be in their 50s and up. Part of it, I think, is just the fat pads that are separating out. And then also I think it's the way people sleep. And so I use a little bit of product, just fine-tuning over the surface of that, and then shape it. And this is just below the dermis now. And I find I just end up using much smaller amount of product for one, and it doesn't overinflate people's cheeks, and it creates just a nicer contour where that shadow now is gone. So to recap, I've done Restylane Define Deep to build up this part of the cheek. That was about 0.2. I did about 0.3 of Restylane Define at the angle of each of her jaw. I put about 0.1 of Restylane Define right there, and then I went back with Restylane Refine in this area, in the commissures. And then I'm going to switch to just regular Restylane.
And what have your patients noticed about the compliance of their skin since you started using these newer refined products?
I haven't. So you can speak to that actually, Jim, if you've, one more of the alcohol, please. If you've had any patients commenting on, and you're talking about both the Refine and Define?
Sure, I mean, I think the area of those, the little puppet lines, beyond the lateral commissure, which are such a dynamic change, especially in a thinner person, that these products will have a little bit different cross-linking, have more compliance and flexibility. And so it seems that, the patients, instead of complaining about, more firmness in those areas, when they animate, they like a more natural look. And certainly we're seeing that with these newer products that have a different cross-linking patterns to them. And I think, especially in those more highly mobile areas, that's where we like to use the refined products, like you just demonstrated, but especially layering like you just did as well.
So the last two techniques that I'll demonstrate are how I outline the lip and then filling lines in. I love filling lines in. I love fine details. And it's usually the last part of what I do. And I can tell you that some of the happiest filler patients I have are the 80-year-olds, and I filled lines in. And they are so happy with that. So when I do the approach to the lip, I usually fill lines in. She doesn't really need any on the upper lip because I think she's had some of that done in the past. And so I'm going to do the second step of the 4 steps that I do for lips. First step is I fill lines in, the same technique. I use either Restylane or Juvederm. And then the second step is I outline the vermilion. And then if the patient wanted volume, I add volume to the upper and lower lip. I first have to have a good idea from the patient how much they want. And then the 4th step of the technique is the commissures, which I just demonstrated. So if the cameraman shows, so I've got the bevel up. I'll bend the needle about 45 degrees like that, and then I would spray it with hypochlorous acid. I just need another alcohol wipe here, which I'm going to wipe that needle. And then this is the only part of the procedure that really is the most sensitive part. So open a tiny bit. I usually don't block patients because when you do blocks, they lose the lip lines and the lips don't move quite right. And so I just go, Corey had shown this earlier, where it allows the syringe to be off of the face. It gives it a much nicer angle for me, and I just go directly right along the vermilion border and then do a retrograde injection. So I do a retrograde injection. I have another entry point here, right along the vermilion border. I will often use about 0.1 for the entire lower vermilion and 0.1 for the upper. Okay, you doing okay?
You got a shot of hypochlorous acid there.
I have 1 shot left. Okay, great.
More than that, that's mine.
Oh, thank you. All right, so thank you.
So relative to that, Patrick, I'm most interested. That's a treatment for. It's a treatment for blepharitis, which is very commonly recommended. And are there studies on bacteria kill or?
Oh yeah, it has a hypochlorous acid has a very broad spectrum of coverage for virtually every bacteria, fungi, and candida. And viruses as well. So it's got, and it's typically in the studies show 99.99% logarithmic killing in 60 to 90 seconds.
Is it in the derm literature?
Oh, so dermatologists have been exposed to this after the ophthalmologist. The ophthalmologists originally were using hypochlorous acid in the eye. Dermatologists have it for atopic dermatitis the last several years for sensitive skin because it reduces skin flora.
Yeah, and actually our ophthalmologist gave a talk on that on Thursday.
Yes. And mentioned it. Meibomian gland dysfunction.
Yes. And so it basically, different than an antibiotic, but it basically allows neutrophils to kill bacteria more efficiently and keep the area sterile. And so it's a 0.01% solution. And now you find it in a lot of over-the-counter products, as well. And so it's non-reactive, as you say. You can put it on mucous membranes within the eye, etc. Let's just cut over to.
If I can just finish the upper lip,
okay,
because so I treat this from the Cupid's bow anteriorly. So I do it on everybody. I think makeup artists always draw that in, and tattoo artists or cosmetic tattooing, they always do that. And women, when they put lip liner on, they always color in that area. So bent needle, 30 gauge needle. This is regular Restylane. I go right at the apex. I'll follow right down the vermilion border like that. It's sensitive. I do a retrograde injection of just a few droplets, and it just creates a really nice defined, I know it's the most sensitive area. I usually give a patient a tissue because it brings tears in their eyes. Then I do a retrograde injection. I usually change the needle between the upper and lower lip because the needle gets dull fairly quickly, and a sharp needle is way more comfortable. Open here. And then I'll get the very corner there. And all of this is probably less than 0.1, and then I shape it. So I like to do it from the top with the patient lying back because I can see the lips better that way, but I'll shape it. I'll shape it like that. I usually use a single, that's a messy one, but if you give me a new one here. Shape it with either a dry gauze or saturated with hypochlorous acid. I single ply it so I can feel the filler, and I can actually shape it like that along the vermilion border. So for 50% of patients that I do lips on, I only do vermilion border. Like I only do the outline because that's all they want, and they love it, and they'll come back. Restylane will last about 6 months. If they're over the age of 50, 9 months, typically in my experience. Juvederm will last about 2 to 3 months longer. And the very last thing after we come back, if we come back, is how I use the same technique for filling lines in.
Okay, we'll come back real quick. Let's
So I finished outlining her lips with the Restylane with the 30 gauge bent needle technique. And then I started to fill lines in on her right cheek. And I think a really important just part of filler is smoothing and shaping. So I'll shape it so nothing looks bumpy at all. For filling in lines, either upper, lower lip lines, the chin line, I filled half of it in actually. Little lines that come wispy in the commissure, and then even these little etched lines in the cheek. I like either Juvederm or Restylane. I like those two products. I smooth them out. They last for several months, and it's like the frosting on the cake. I think if you look, I've done. Now, you can't stop those lines when they smile, but you can certainly soften them so that a face that's resting, it looks smoother. And then I've also gone with the Restylane to just do fine tuning. Again, this is just kind of in that mid-subcutaneous area where I will inject and then shape so I can get the contour looking very nice. And then I see where I would do the same thing. I would just add a little bit right there. So I'll demonstrate a technique that is similar to using the 30 gauge needle that you saw with Dr. Moss. But I like to do a linear threading with a retrograde injection of lines. And she has one right here. This line that you can see, I can accentuate that line. It's partially a sleep-related crease. So and you have to correct a line like this, you have to be in the dermis. You spray that again just with a hypochlorous acid. It has to be really an intradermal injection. If you're injecting below the dermis, you end up bulking it up too much and you still have a line there. That's what happens so often in the upper lip when people are trying to make lines go away. So that's why I bend the needle, because now the tip of my needle is parallel to the skin and it runs straight through the dermis. You can see it even came out. Okay, very superficial. That's where all the nerves are, so it's sensitive. I do a retrograde injection. like that. And then I smooth it out. Etched lines, especially those on around the lip that run into the vermilion border, commonly need a second session because those etched lines, you can fill them in a certain amount. They've been there usually for years. And then I'll go right here. So that was the last of the technique that I wanted to demonstrate, really this fine line technique of just a retrograde injection and then smoothing it like this. And then one last point that I do with fillers is I have patients smooth it at home for 3 nights. And I tell them how to do it. And I show them with the mirror exactly where to go. So if I fill upper lip lines, lower lip lines, if I do the commissures, if I do this, if I do glabellar lines like this, I'll point out to the patient, I want you to take your finger with a little moisturizer on it, starting tonight, that night, because usually they're getting one of the neuromodulators at the same time. I don't want them rubbing for at least 4 hours. So start at night, I have them do 10 strokes on the upper lip on both sides, 2 fingers in the commissures like this, and like this for any lines that I've done. And they do 10 strokes for 3 nights in a row, each night before they go to bed. And I never have issues with bumps, ever. Especially since I do a lot of superficial and dermal injections. So I would have her just go home, I would show her, and then I would show her, like on her back of her hands are numb from Dr. Lacombe. So I would have to just show her what kind of pressure to use, like that. And I've done that for years. If it's lip, if it's cheek volume that I've added, I don't have them shape that. I don't have them smooth that. And I don't have them shape the lip. It's just those upper lip lines and lower lip lines. All right? So I'm going to finish lines on this side for you here. We should really give you a mirror so you can see what we've done.
How many syringes total have you used on her?
So I've almost done 1 of Restylane. I did almost 1 complete one of Define, and the Refine, I used maybe 1/3 of that. So she's had a total of 1, 2.5, maybe 2.5 syringes, 2 to 2.5 syringes. So I use whatever amount I need. I think I typically now for this kind of global treatment with filler, I give patients just a price rather than per syringe. And they're paying you really for your artistry as opposed to paying you for a commodity. And I completely agree with Dr. Moss. I didn't always do that, because people price syringes, they think 600, of one, 550 is the same, and it's not. People should pay you for your artistry, especially if you're sitting here learning how to do this really well, or you've done it for 30 years. Okay?
Okay, great, thank you.
We hadn't met. Lynn is a friend of mine, but she came and had her lips. We talked about. I didn't know that she had her lips done, so I wouldn't recommend doing her. I looked at her lips and I said, "You don't need your lips done." So, and she agreed. Yes. Okay. So she has a little bit of a marionette line and some fine lines. And just for purposes of demo, because I talked about the 10 milligrams per deciliter being or milliliter being the which I was corrected on earlier, thank you, being the threshold for Tyndall effect. And we can do the same thing with Juvederm XC, which the thing about Juvederm, which is the original one, which can be used to your advantage, this is the most hydrophilic of all of the HA fillers by far. And so if you do it in a nasolabial fold, actually, you get a lot of water correction along with you don't need, rarely would you need more than a syringe to fully correct both sides of nasolabial fold with this product. It doesn't last forever because the water retaining capacity of most of these is gone within 4 to 6 weeks, but if we can make it less concentrated, I can just demonstrate again the simple way of doing this corner of the mouth treatment, which does have a little zing to it initially. Are you a little nervous?
Yes.
Okay, we're gonna be fine. So the first couple are zingers, but so I don't know. Can you see this on the video? Turn your head just a little bit to your left, yeah. So you can see the crease here, right, at the corner of her mouth, and that's a real depression. And I'm just going to demo what I just did a moment ago with this is a 31 gauge needle, and if you place this needle intradermally, and the first couple are zingers, and then the subsequent ones are really, I don't think you feel those next ones. So after you get the first couple in, it doesn't really hurt, and we can make this transition smooth so she doesn't have that little downturned corner of the mouth with a very small amount of product. And I would, in our practice, this would be a minimal, I told you minimal, mild, moderate, and severe. And it's about our time, and whatever the amount of product is doesn't really matter. Just for your inventory purposes, when you spend hundreds of thousands of dollars on these products, or millions, inventory management becomes a really big deal. So even with small treatments, you want to account for it, but that's really just for that purpose, accounting, which I'm not very good at. Okay, so we're almost done. Are you on this side? Are you good? Okay. So we see a little bit of extrusion there, which when you get to I'm going to lift your chin just a little bit. When you get to the limit of sort of tissue turgor, you'll see it escaping the skin through pores, and that's as much as you can lift in one session. I'm going to try a different angle here, a little pinch. So these are truly intradermal injections, yeah, with a little bit of extrusion, which was always, I was just talking to Dr. Bitter about this, the old days that was always sort of the collagen nemesis, when you got to the point where you were injecting intradermally and it was finding some pore to come out, and that was often discussed with collagen. But so you get as much as you can in, and if you need a little more the next time, you do that. So she's close to her limit, but the line is better, and I gotta get it dropped up here. But again, you can do this without puffing the lip all, so I see a lot of people, they put the needle in and they do this great big V and the whole area gets bigger. And you have to really sort of hyper-correct the area around the lips to balance everything out. And this is a way of doing it with very small volumes of product. No, I'm good here. So that's it, James. I don't have more to do on her. Her lips look nice. Yeah, I just did what I did on the other side here, and you can see the area that's blanched. You can see the area that's blanched, and a circle of, which is really common, of tiny little dots. Are you hearing that okay? Is that projecting? Okay, so there's a blanched sort of oblong area here, but that, if you remember, was a crease. And they do get this little tiny micro dot bruising, and that's something they can cover up with makeup. I don't have any problem with makeup. As long as you prep the area when you're doing the treatment, I think that's really important. I said that before. It's under discussed, and that's unfortunate, because these are actually implants, and implants, you need to treat them with gloves and prepping the skin and avoiding these sort of biofilms and other phenomenon that are unnecessary, unneeded, to the extent you can. And
Well, I had the opportunity to look at Christy earlier, and we've kind of gone over our plan, but I just wanted to make a couple of points, much as Corey stated, that probably, I mean, the injection technique with neuromodulators is really important, but more important is the injection planning. What are the goals that the patient has, and what is possible, and what can you offer them? And sometimes you can't achieve that. Patients have a concept that neuromodulators, in this case Botox, is a filler, and it's not. And they'll point at a wrinkle and say, I don't like that wrinkle, I need a shot right there. Well, of course, that isn't how it works. The neuromodulators are affecting dynamic wrinkling caused by muscle movement, and you've got to identify the muscles that are causing the movement and get them to quit moving. And then generally, I tell patients it takes about 6 months, that would be, with our current dosing, that would be 2 injection sessions before you'd actually be able to really see things flattening if you have deep lines, before you make a decision as to whether neuromodulators are going to work for you or not. And Christy has had neuromodulators before. She's had several different ones at different times, I guess. And we made the decision to use Botox today. But she's about 8 months out since her last injection. So you could kind of consider her to be a bit of a neophyte in terms of where she is and what we want to treat. And the big caution here is, as I think it was Dr. Moss mentioned, we want to avoid the squashed bat look, for most patients, where you immobilize the forehead. People think they don't want lines in the forehead, but they actually really do. And if you eliminate any forehead movement, unless they've got a really tight brow, they're going to collapse their brows into the eyelid space, and then they're going to come in and say, I want a blepharoplasty. I want all this skin out of my eyelids. And so one of the first things is to look at somebody like Christy, and she demonstrates a couple of important findings. She'd like to get rid of the lines in her forehead. Go ahead, Christy, raise your eyebrows for me. And now relax a bit. And even when she relaxes, she has these lateral lines. And the reason she has those lateral lines is because she's working hard to keep the lateral brow up, because it actually would create hooding into her eyelid space. And that's typical. My wife actually calls these her standing waves. And so you have to be careful, because if you drop this lateral area, you're going to drive tissue down. So what I usually do is, patients want to eliminate these lines, then I'll always do a bit of an injection into the lateral orbicularis, because the orbicularis pulls the brow down, and by injecting it, as we've discussed today, it will allow it to rise up even in the presence of a relaxed frontalis. The other thing that happens, if you don't inject out here, you're going to get the look that we saw earlier today of the lateral brows being pulled up. And if you have to balance that with some kind of medial injection, and I'll talk about it in a second, but I actually kind of get one of the depressors, one of the effects of the corrugator muscles is that it also functions as a depressor of the brow, in addition to the orbicularis. So when I'm treating the glabella, I'm actually also going for elevation of the medial brow to keep the symmetry of the brow so that patients don't spock their lateral brows up high. So, and then we're going to also treat a bit of her central forehead and the glabella, and then smile for me. She has fairly pronounced crow's feet with smiling, and so I will place 2 injections in this inferior orbicularis, which in its contraction is causing the skin to wrinkle, and we'll try and inhibit that to minimize her crow's feet. So that's kind of the basic analysis I go through. I am using a lower dose of Botox. Each injection site will be only 2.5 units. And in my hands, that seems to be adequate for patients, but as we discussed earlier this afternoon, it may be that if patients want to pay a bit more, we can stretch this out and perhaps have less injection sessions per year. So we'll go ahead and do these fairly quickly. And again, the first thing is the planning. The second thing is where you put the injections. Now, hopefully, Christy's numbing medicine is still working here, but. So the frontalis is a relatively deep muscle. So I'm going to put in the 4 frontalis injections first. So these tend to go fairly deeply. Turn this so we can see here. And then we'll get these. And then raise your eyebrow again. Okay, relax. We want to get this one. And in my experience, that leaves a little bit of movement here in the center. If they continue to move too much, then I can touch it off, but I don't want to leave them totally without forehead movement. And then for the corrugator, the corrugator is also a deep muscle. It's behind, posterior to the orbicularis. So these corrugator injections near the head of the brow are deeper injections. And then we place one for the horizontal furrows to get the procerus. And then we have, let's see, I think we've got exactly, yep, we're perfect here. So now for these lateral injections, the depth is different now, because our direct target is for the orbicularis, and the orbicularis is right below the skin. It's not deep. So these injections, we want to have more superficial, and I actually raise a little bleb for these injections for the orbicularis. And the good news for the patient is these injections actually tend not to hurt as much as the deeper ones. Is that true?
Not bad.
Not bad.
Dr. Sutton, you mentioned when somebody, you get referred a patient who had Botox or Dysport, they just got a sudden onset of ptosis. What do you do in their management?
Well, first of all, most patients aren't real happy when that happens. which is one of the reasons I'm not in a big hurry to increase my dosing, because I really don't see many complications. I do see some ptosis. It's pretty rare, but I know that if I increase the dosage, I'll probably see more.
Let's say you got somebody who's just got like a 1 millimeter mild ptosis, and you just want to give them a drop that'll help.
Well, right, and so the most important thing is to reassure the patient that this happens, and it's pretty idiosyncratic. We really don't know why a given patient. It's not like if they come to my office referred, it doesn't mean that the doctor did anything wrong. I can inject patients the same way multiple times, and then all of a sudden, one day, they come in and they have ptosis, and I haven't done anything different. And so you need to emphasize to the patient that it's an idiosyncratic thing that happened, that doctor didn't do this like on purpose. And the other thing is the good news is this will wear off before the cosmetic or therapeutic effect of the Botox wears off. It usually comes on, it's actually usually a week or two after the injection they really start noticing it. And it tends to peak and start getting better at about 6 weeks. So the beneficial effect continues beyond the complication effect. If the patient just has a little bit of ptosis, you can have them get Nefazoline, which is over the counter at the drugstore. It's 0.5% Nefazoline, and that will kick the brow up a little bit. If they want something more, then you can write them a prescription for aproclonidine. If I remember it, it's 0.5% is the way it comes. And they can use a drop a couple times a day. It lasts maybe an hour or two, so if they need to go get wedding pictures done or something like that, it can be very helpful. On the other hand, when it wears off, their eye can turn red. So they can get that idiosyncratic effect. But at any rate, it does help get the patient through that ptosis problem. Unfortunately, if they get double vision for some reason, which can happen, aproclonidine won't work.
Okay. Any questions for Dr. Slide?
You're all set.
We're going to be getting our...
All right, so over here we have Brett, and Brett's been very gracious to volunteer for us. She's local, and just scooch back a little bit. We're gonna have you sit straight up here. So we're gonna do a little bit of commentation just on her face. She's got a very long, thin face. She's a little more hollow on the left side of her face and cheek than she is on her right. She's similar in some ways to our first patient, in that she has a lot of hollowing underneath her eyes and flattening to the upper cheekbone. Again, more on this side than the other. She has pucker force a little bit. Okay, she has a fair amount of wrinkling on her upper lip. She has a nicely defined border in this particular case, but she has some deeper creases out through here. She has a scar over on her cheek right in this area through here, and some creases on her lateral cheek, and a little bit of the downturn to the corner of the mouth, so similar to some of the issues we dealt with in the last patient. She has some deeper frown lines in her glabella up here as well. And so, again, we're going to use a combination of products that we dealt with in the last patient. One of the things that I was going to demonstrate is how, because I do block everyone every time, I was going to show you the block and how quick it is and how quickly it can be incorporated into your practice if you use it on a regular basis. So I'll give you this little squeezy thing if you'd like to hold it. So just relax your mouth, keep your teeth together, and you're going to feel it. Just keep your chin down like this. Okay. Oh, yes, right. She got hit in the upper lip with something, which I don't understand because I don't live up here, but it's something you threw up on the roof, and it fell back down and hit her upper lip. So when I pinched her, she felt that a little more. So this will actually help that feel better. Okay. So I'm using a lidocaine with epinephrine. I usually buffer it, but we don't have buffer today. And I use a 1-inch 30-gauge needle. Okay. So I'm going to keep my finger down here, right on the infraorbital nerve. And I'm going to shine it in through here, shake her lip a little bit. I'm going to land right down on the bones, similar to the nerve, and give a little teeny bolus there. Slide it over next to it. Okay. As I come up, I'm going to give it a little bit right in the mucosa, kind of similar to the little mini blocks that Joe Niamtu talks about. And a couple of those across the mucosa underneath here. And then we're going to give the same one up on this other side over here. Okay, my finger is right where the orbital ring is here. And again, just little teeny bits, Should start working very quickly. Okay, down in through here, teeth together again, but chin down. Good, so the camera can hopefully see a little bit. So I'm pulling out through here. I'm going to go right along the mucosa here, hanging down right to where the mental nerve is. And I'm going to give it a little block. Aim down along the groove, aim back all the way to the back of the angle of the mandible. And then again, little teeny blocks here, right by the frenulum. 2 or 3 here. And then again, aiming down to the mental foramen. And then the last one again, back along here. So the tendency is for the patient to want to open their mouth. I help them keep their teeth closed. So that was relatively quick there. And avoids a lot of the topical numbing cream. Are you starting to feel some numbness? Okay. Let's just see, sharp or dull? Good. Anything sharp? Perfect. Okay, so we're all ready to go. She's already been wiped off with the alcohol. I'll do that one more time. Again, in respect to time, we're just going to do up one side and revisit some of the things we did before. Okay, so again, this is a syringe of Voluma. She's very deep in through here, so in an ideal world, she would probably need more than once, but most patients' budget only allow one syringe underneath each eye. This is what oftentimes people start with. She doesn't have a deep nasolabial fold, but she does have some of the creasing near the surface. Usually nasolabial fold is sort of the bottom of what my sort of consultation, it's like the last thing I sort of recommend if that really bugs them. So usually it's the corner of the mouth or along the jawline here for the prejaw sulcus, and that's what we aim for. So again, my finger reaches up here and touches the orbital rim. I squeeze this up through here and I'm not touching the area where the needle goes in. And we're landing on the bone, sliding up, and then little sort of boluses of 0.1 or 0.2. You feeling a little pressure?
So unlike the Gerber, you're on bone.
I am
Zero problem.
only injecting on bone. So there's no coming off of the bone, I'm only injecting once I feel the bone. So you see my needle moving left and right. That's because I lift up and I move left or right. But again, I don't inject. And see, I'm a little more lateral here and that area doesn't get numb.
So actually, you're in the area of V2 and your orbital nerve.
I'm way above it.
You're way above.
Yeah, I'm right at the edge of the orbital rim.
Okay.
So I'm much more superior to that.
Okay.
Okay, so again, I just hold a little pressure right here. So I've used so far 0.3. So I go in very close to where V2 is, but when I go in, I'm superficial and then I angle up above it and I'm landing right at the edge of the bone because I can feel the edge of my bone because my left hand forefinger is touching the orbit, and so it's right at the top of the orbital rim. And I can feel my needle is right at that point. So the actual V2 foramen is well below me. And each little injection here is like 0.05 to 0.1. And I move along and just create little BBs as I trace along the rim there. I can actually see it lifting up. I'm heading upward this direction. I'm going further in to get up to the orbital rim as it angles superiorly toward the medial most aspect. So I am way up here now. So I'm just going to massage that a little bit right now. There's a little numbing medicine mixed right in there. Okay, so I've got a little indentation here. I can see the rim is up around through here. I haven't gotten to that point. You might feel this a little bit more. Chin up just a tiny bit. Okay, good. My finger, see, you can feel see the rim is all the way up here. So people think it's down here, but it's really way up there. A little pinch here. So I come in here and I angle my needle upward and land way up here. So you'll see that lifting up and filling in. See my needle way up there.
Sometimes they'll have a little more sensation when you touch that periostea.
Right.
And they'll let you know.
And especially laterally where it doesn't get numb from the infraorbital block. But I always reassure them that there's no medicine mixed right in with it so that it gets done as we go. And take the needle out. Okay, that side's done.
And the total volume used there?
That was 1 syringe.
1 syringe.
Okay. So in an ideal world, we probably have more in order to continue this out and up and around and out towards the lateral cheekbone there. So you got the little lips on your lap.
And you're using Voluma.
Using Voluma. So again, like Dr. Bitter, my choice underneath the eye is either Voluma or Wrestle and Lift. And I tell patients in my consultation, you have 2 choices. They basically will give you the same result. The main difference is longevity. I tell patients either 2 years or 1 year, and the main difference is price. In my practice, I charge either $600 or $1,000. And so really it is a matter of sort of either renting or purchasing. So it's kind of like moving into a new neighborhood. You can rent and try it out, or you can purchase for a longer time frame. And so Define is also a good one. It's just the price point's sort of in the middle somewhere there, and so it's a little trickier. I do like the Refine for the lower part of the face, from high movement areas like the corners and around the lip. Okay, so here is the lower eyelid on this side compared to the hollows underneath there.
There, you can get a close up there. Very nice.
Okay, chin down a little bit there. Okay. All right.
Any questions about that before we switch back over to Dr. Bitter? We'll let Dr. Lacombe continue that on the other side.
Okay. So now what I'll do is I'll actually have her just hold pressure on this side. This is what I typically do in my practice, is she holds firm here. That helps to minimize bleeding and bruising and swelling even as we go to the other side.
Okay, so let's come back to Dr. Bitter's kind of framing out the face, like you said, with the face.
Okay, so I finished up here and we treated both sides of her eyes, here and here. And now we have some Juvederm to inject. And so I'm going to show a few things that we've seen a lot of injections around the lips and the mouth, so she needs that for sure. She actually has a super nice defined Cupid's bow and lip border, though she does have some little creases in through here. Brett, you're 42, is that correct? Mm-hmm. Okay. Have you spent most of your life living here in Tahoe or in the sun? Mm-hmm. Okay. So we see some, solar aging changes. If we could actually pan back out a little bit more. So some of the things that we see in her. Turn your head over here a little bit for me, and actually sit with your head down just a little bit here. Okay. So if we can see here, she's got a little pre-jowl sulcus here. Okay, and here, okay, and she got a deep crease, that's her scar, and then she's got this crease that comes down in through here, into this pre-jowl area there. That's a little bit close, yeah, that's fine. So one of the things that's really nice, if we can address is, and that I'm working a fair amount on these days, is filling in this pre-jowl area here and here. And one of the common mistakes is filling too superiorly on the mandible, when we can just fill really right down almost below the mandible. So this is the edge of the mandible here, this is the bottom edge down here, and we actually just fill right along in through here. So the question earlier was, where do we put that? And I generally start with an injection that goes perpendicular and goes right down to the bone, and then as I inject, as I pull back, and then sometimes we can actually follow along parallel to this little crease. And a good tip is you follow it where the this crease takes us, because you see this folds over right here. Now you're going to hold your head real still and not move it for me, even though I may move you around a little bit. Okay, so you see where this comes out here, and I can pinch it. It pinches up right in this spot here. My thumb is right here underneath the bone, and I'm going to just take it and pinch it and pull it away from the bone, and I'm going to stick my needle in right down to the bone here, and I'm going to start injecting. And actually probably the wrong needle, it's a 30 gauge needle, but I can still do it. And she feels it because it's right on the periosteum. I move my needle left and right a little bit. Put a little bolus here, and then I inject a little bit as I come out. So I can actually feel a little ball here. I'm going to massage it a little bit. It's deep. Okay. And I'm going to probably take a little bit and follow parallel to this little crease here.
So you did it deeper and you're layering that.
So yes, right now I'm layering because she has such a deep groove here, right there. Okay, and I'm just going to massage this a teeny. So because not everyone has such a deep crease that comes along through here, I don't always put that little more superficial one in through there. So if we can see now, it's a much straighter jawline here than what we saw before compared to the crease over here on this side. And I used like 0.25, okay? So that's really easy, okay? I don't know if that shows up.
It does.
Okay, good. Okay. So for me, I've been doing a lot of patients and using a fair amount of volume to create jawline straightness in this area through here. And I've actually injected myself too in a lot of my patients. And I've done a lot of dissection along the masseter in that area. And it's hard for me. I mean, I can get my needle down on the bone back here, the angle of the mandible, and I can inject in there, and it looks really good, but it hurt. I was sore in my masseter for like about a week or so afterwards, and so some of my patients experienced that too. It still looks good, it doesn't hurt anymore. So I've been doing a lot of the same injection right here at the back at the angle of the mandible, but more superficial. I haven't seen too much problems with it moving around there. And I know that when I've had to dissect with an elevator, that it's pretty hard to get it up and out and get between that space on the periosteum where the muscle goes down. So I suspect that some of my injections have been going into the muscle in that area. I don't think it's a problem because I haven't had any problem with it. It's just that it's kind of sore. So I've been doing more injections in through here because I think when I inject in that area, it's going into the muscle. And again, not that it's a problem per se, but it's just uncomfortable. It hurt me. So anyway, one other thing which is super off-label, and I wouldn't recommend it for everybody, but I'll show you because we're here. So relax your forehead for a second. So she's got some really deep grooving going in through here. And so this is an area which has been problematic for a lot of people and can be risky for a variety of reasons, including blindness and skin loss and sloughing. So again, that's why I'm prefacing with this with you shouldn't do it. But a lot of people have deep grooves that don't go away even when they've had Botox for a long time, just like she does. You can see a very deep groove in this area through here. And so I don't recommend injecting into the dermis or in that area. But what I have done for a lot of patients is when we go right into the groove in this area through here, and I tent the skin up, you're gonna feel a little pinch. Yeah, sorry. Okay, and I go straight down to the bone, and then I tent the skin up and away from it, and then withdraw back. And because I'm on the bone in this area through here, and I do a lot of endoscopic brow lifting, and once we're down onto the periosteum in this area, then I can do a little bolus in this area through here, and inject as if I'm pulling back in this area now. And that just fills in a little volume in through here, and I massage that around. And again, I'm not injecting perpendicular forward, and I'm not injecting into the dermis, and it's not parallel to the where little vessels are there, but it just creates a little volume, and sometimes it can even lift up a portion of the brow, which you've seen people who are really sunken in this area, who just need a little bit of volume. And oops, sorry, up or down? Okay. So again, very circumspect and really super deep after tenting all the other structures with all the blood vessels in them up and out, and not paramedian on the sides here where we know those vessels lie. But again, we're here to learn, and it's super off-label. And again, not that I'm selling it because I don't make any money off it, but I do have a textbook out, and the second edition just got released. But a lot of these things you find in there, and all those are starred, kind of like a Zaga guide, with very difficult or very risky and so forth. But so injecting the forehead, I think that is a good place for a cannula. And so you would just pop in, I'm not going to do this for her, underneath the wrinkle with a longer needle or a cannula. And one of the tricks I learned is just rolling your needle or the cannula along here, and then injecting as you're coming back in that plane that's not intradermal but sort of below the dermis, and injecting as you pull back. Again, I'm a big fan of injecting as one pulls back, and then really filling the space that the needle left. Okay, so even when I inject, let's say, vertical lip lines, I inject it parallel to the lip, but I put so little force into that as I pull back that I'm not expanding the lip, but just really filling the tract of the needle. So I like to think that I'm just filling the tract that the needle had put in there and pulling it back just to fill that space. You know, she's got a little scar over here, which we cleaned and wiped off. And this is a place where I really typically wouldn't use a lot of Juvederm. And I think the needle does a lot of work as far as subcision. So several little teeny passes here that break up the tissue. And again, just with a little tiny, you know, filling through here. I don't even try to completely correct it. And that over time, if we were to do this multiple times for her, I found that scars tend to, I hate to say heal themselves, but a little collagen grows in, and I end up not having to fill a scar like this, whereas this crease is going to need continual filling over time. And Juvederm wouldn't be my treatment of choice for this area because it oftentimes shows cat scratching or ridging up afterwards. So that's where I would use a different product, whether it would be Velour or Bobella for this. If someone only has one product, I would probably maybe do multiple separate little teeny passes in this area without trying to completely correct it, because I know it's going to swell up and then it's going to look rigid up for like a month before it sort of settles out. Once I've done it, it can last for 6 to 9 months or more, maybe even up to a year, but they're really unhappy for that first month or so. So again, I try not to use this particular product for that area.
Okay, great. So we'll let Victor finish up there and prepare for the next patient here. We're gonna...
That it felt just a little bit harder, but I wasn't in no pain whatsoever.
Yeah, great. Okay, so let's focus in on Miss Raquel here. And it's great having young patients like this. These are going to be part of your patients who are part of your prejuvenation. And I think we're seeing more and more young people coming in asking about neuromodulators as social media and Instagram and I mean, we're seeing some 20-year-olds come in. Now, granted, some of those just have very strong muscles for their age. But in Raquel's case, she has you know, a little bit of minor asymmetry. Just look straight at the camera now. And what you'll see is that her right eyebrow has a slightly higher arch to it. So that's one thing you want to point out to the patient ahead of time. We also evaluate for the eye opening, make sure there's no pre-existing ptosis, and she looks good there. Go ahead and let's have you frown for us here a little bit. Really time, okay. So she's got fairly symmetric corrugator function. Now just relax there. And go ahead and let's see your frontalis in action. Go ahead and raise your eyebrows up. Okay, so she's pretty good there, but you do want to point out that little bit of pre-existing asymmetry. So sometimes when we have that situation, we'll take a mirror and have the patient look and say, which eye do you like better? And in this situation, we'll give the mirror here. She has pretty eyes on both sides, but we'll ask her, looking straight at the mirror, which eyebrow do you like better? Okay, yeah, that's the one with the higher arch. So we obviously want to be cautious and not do anything that's going to drop this brow down, and we'll try and do some strategies like Dr. Moss and Seif showed about maybe bringing this arch up a little bit by treating the lateral orbicularis. So in this case, we're going to be using the Dysport product. For the rest of our physical exam, we'll basically just palpate, see if the patient has a little supraorbital notch or just foramen. In this case, she has a pretty prominent notch there and a little one here. So you can tell where those vessels and the nerves are going to come out. So obviously we want to avoid injecting directly into that area. So we'll do the medial club head of the corrugator, skip over that notch area, come to that lateral component. And with Dysport here, you know, if we look at the labeling, we're going to use about 60 units of Dysport, which would be the bioequivalent of about 20 units of Botox. We could use a little bit less. And we're not going to do anything to her frontalis because she has very mild lines. And, you know, we'll talk to the patient and say, look, if we knock out your depressor muscles, your forehead might become a little active initially, but then it'll kind of relax on its own based on some biofeedback. And if the patient is concerned or they develop some hyperdynamic lines in their frontalis, then that's a perfect thing to have them come back after a month and treat. She doesn't have any really lateral crow's feet lines at rest, but we're going to try and do some things to bring this brow up. So she'll let us know in a couple of weeks how things work out. So we'll go ahead and get started here. Technique is nothing different than what you've seen before, except we do like to have the patients leaning back to where they're comfortable. And again, just palpating here and coming right in here, and we just come in with a little bit here and come lateral here and more superficial as you come laterally there. Okay. So that's right at about 30 units of the Dysport on this side. We're going to do the same thing on the other side. And these little BD syringes are great because they have a 31 gauge needle on them, so they're not as painful as using a 30 gauge. And frown for me one more time. Good, perfect, okay. And we'll just get that last little part. Okay. Then for our asymmetry treatment, go ahead and smile for me again. Okay, good, now just relax. We'll just do a little tiny bit on her lateral orbicularis. I'm not going to put anything up here where her arch is because I don't want to hyper raise this one and make the asymmetry any worse. Then we're going to come along her left side and come along that lateral orbicularis, put in a little bit more and a couple little wheels here. And then we'll do a little tiny bit just in the procerus. Great. Okay, so we'll give this a little bit of time and see if we can bring that brow up. But Dysport, typically the ratio, we use about a 3-to-1 equivalency with the Allergan product, and that should work well. So we'll come back to Dr. Mraz here, but any questions about Dysport before we do that? Okay, very good. Thank you very much, Raquel. Okay, and we'll have Dr. Mraz wrap things up there.
Okay, so you can see it has instant swelling, and I do tell patients. So we're going to demonstrate Sculptra. Can you hear me? Put it up a little higher. Sculptra, I did bring a centrifuge, and so we've mixed Sculptra with PRP. I've done a 2-to-1 ratio of Sculptra to PRP, and I have Dr. Campbell as my model, who fortunately is already young and beautiful. I say that Sculptra is a great product for making a beautiful person even more stunning. It's louder. Okay. Let me put this closer to my mouth. Can everybody hear me? Yes? Okay, great. So Sculptra is, as many people know here, a collagen stimulator. So it is very different from other fillers in that it is more gradual. It is conducive for a little more global build and lift. I love Sculptra for kind of structuring of the face. Dr. Campbell feels like her face is falling a little bit, And usually we don't treat patients with body dysmorphic disorder, but in this case, we're going to anyway. So it's a great product. A lot of times people think of, using Sculptra on an 80-year-old woman, and I have older patients that love their Sculptra results. They need more of it than a young patient. So they just need more sessions, but it's also great for building up the structure. But don't forget about it with the young person who is just needs a little umph, something to make them feel a little better, right? Yeah.
Young. 38 is
You're a baby. You're a baby. So Dr. Campbell's actually had a little Sculptra already. She's really 104. And what she feels is that her face is kind of getting a little anterior descent. So we're going to use this really to basically structure her up a little bit, middle third of the face, upper third of the face. We're going to use some in this preauricular area to kind of strut things back. I will use just a little in her piriform aperture. I think that'll give her a little anterior projection as well. Okay, yes, I've already alcoholed. We're gonna ice and then re-alcohol. So I do like to, like many of the other injectors today, I do like to keep my patients busy. It actually occupies them, so I put all my patients to work, holding a little ice and then holding a little pressure afterwards. And in addition to talk aesthesia, as your product has likely, your numbing has probably completely worn off by now. So
beauty is pain.
Beauty is pain, that's right. I always make sure the product is flowing before injection. I'm going to go down to bone and then slide along bone. I'm going to aspirate before injecting. Just give her just a tiny bit, really in her mid-cheek, to push up from underneath. I'm going to turn your face that way a little bit. So I'm on periosteum, and before injecting, I'm always withdrawing. This does two things. One, it helps to keep the product flowing, and it's also a safety measure. And I've trained many people who have actually gotten a flashback. And in fact, I've gotten flashback myself. With a 25 gauge needle, with a fluid product like this, if you are in a vessel, you will get a flashback, which is somewhat reassuring to know safety-wise. I'm going to kind of come from the other direction, a little pinch. How's that feeling? Great. Do a little along the inferior zygomatic arch, and this will actually give a little rise to this mass.
So, Sabrina, can you comment on your reconstitution of your Sculptra?
Yes.
And then how you added again to your PRP there?
Yes. So my typical constitution for Sculptra is 7 cc's water with 2 cc's of lidocaine added just prior to injection.
So you have 9 cc.
So 9 cc dilution total. What ends up happening is that you'll get slightly less than 9 cc's per vial. And the reason for that is that there is a little methylcellulose foam, which is not usable product. So there's about a 0.5 cc that ends up as a non-usable product. And it's, we're trained to use every last drop of everything. This is, and I hate waste, but in this case, you don't want to fight with that methylcellulose foam at the end, because what happens is you clog, and bubbles, foam, air are all not your friend with this. They will clog the needle. You will end up sticking your patient multiple times, and you will not be happy and your patient will not be happy.
How far in advance can it be constituted?
So up to a month ahead of time. So I prefer at least 72 hours, and a week is better. A week is better. So I use a lot of Sculptra. I have a bin that's ready to go, just like any other filler. If a patient wants Sculptra that day, there is Sculptra prepared for them. We just add the lidocaine at the time. You don't want to add your lidocaine at the same time, a week in advance, otherwise it will not be effective.
And so, just say one more time what your ratio of is of the PRP to your Sculptra.
So the ratio in this case of PRP to Sculptra is 2 cc's of Sculptra to 1 cc of PRP.
Okay.
And I will most often do, go ahead and open your mouth. Again, so I'm going into the temple area, and again, aspirating.
Which layer are you injecting?
So this is supraperiosteal.
Do you feel bone?
Yes. I'm directly on bone.
And what's this needle are you using?
This is a 25 gauge, 1.5 inch needle. And I prefer the longer needle. The package insert calls for a 26 gauge. I don't really know anybody who uses a 26 gauge with Sculptra. I think you just have a lot more headache. And again, I'm supraperiosteal. You can see her, I don't know if you were able to see her whole brow just lift with that injection. Okay, I'm gonna come up. Sometimes you can't get all the way up there. Do just.
So you get a lot less clogging with the PRP Sculptra mixture.
Go ahead and open up one more time. I've been doing Sculptra long enough that I actually don't get a lot of clogging with Sculptra. The keys with that are, again, being absolutely certain that you don't have any air in your syringe prior to introducing, sorry, you go okay? Prior to putting the needle on. So I get every last drop of air and methylcellulose, or my assistant does. And in this case, I drew it up myself. Go ahead and put a little pressure. But if you keep that needle moving, if you're aspirating and injecting, you're so much less likely to clog. So the key things, having the product mixed in my practice, my assistant is actually pulling up the next syringe as I'm injecting one. So we don't have it kind of sitting around like I did today for the purposes of this demonstration. But you want to make sure that you have this nice, milky, homogeneous solution in your syringe. A lot of people think that they can kind of mix it by going back and forth, but what actually works so much better if the product settles out in the syringe is to roll it between your fingers like I'm doing right here.
Okay, great. We'll let you continue on the other side there. We'll come over to
Okay, so this half of the face has been treated, and I don't know if you can appreciate she's a little fuller, but she's had 7.5 cc's of fluid put into this side of the face. Temple is certainly fuller. This is her hollower temple. The cheek is a little more lifted, and she doesn't have as much of a line of demarcation. Now this is going to go down. I tell patients that in about 3 to 5 days, this fullness will be completely kind of back to baseline. And then they'll get a build of their own collagen, which is much prettier than a fluid fill. So it's there's nothing more attractive than a patient's own collagen, their own structure. So we treated again here, and I put a little on the angle of the mandible also, just again to replace that very, very, very minor loss of the angle of the mandible there. And a little in the piriform aperture, which I'll demonstrate on the other side. I don't think people saw that. So piriform aperture, deep on periosteum, withdrawing first. The angular artery, people always worried about the angular artery, as do I. Branches. The angular artery, when you do these facial dissections, is actually closer to the skin on most people than it is to bone. So when you're right on periosteum, I've done so many of these, and you never get a flashback. It's just, but I always recommend withdrawing, always, always, always. Okay, so I'm on the contralateral side here. I'm going to come over to this side, and I want to I usually start in the mid-face, but I would like to demonstrate that piriform aperture. Good. Again, make sure your product is flowing before putting it in the patient's face. Pinch. And we're down on periosteum. I am withdrawing. And slow injection. And I'm actually repositioning my needle. Sorry. There is lidocaine in this product. So it's also important to warn your patient that their lip is going to feel big, even though it won't be, unless you're doing filler in the lip also, in which case maybe it will be. But they will get a little infraorbital nerve block, so the lateral upper lip will be numb. I'm going to retract the skin, a little pinch. Sorry, the topical numbing has completely worn off by this point. And I think if you can train yourself on a one-handed aspiration, it's, I think, just better for not moving your needle around, etc.
Generally notice since you started using PRP and Sculptra, when did you start doing that, and what have been your observations compared to when you're just using Sculptra alone?
So there's nothing like your own personal experience. I've done Sculptra with PRP and I've done it without on my own face. And generally, if I'm using the PRP, I will do something on the surface of the skin, like microneedling or fractionated laser. I will say that the results seem to kick in faster with the PRP. You can't really replace the Sculptra volume with PRP, so it's an add-on. Yes. It's an add-on. In a thinner person, that little extra volume is absolutely fine. If you've got somebody who's a little fuller, you just need to warn them that it's all going down. Okay, I need an assistant over here.
Okay, so
we'll go back.
Beautiful demonstration there, and you do the massaging, your instructions.
Yes. So I have patients, the easy thing for patients to remember is 5-5-5. 5 minutes, 5 times a day for 5 days.
Okay.
I tell them if they can at least get in morning and night, and recommend that they massage while they're washing their face and then putting their creams. Take some extra time and massage so you get at least 5 minutes in twice a day.
Okay. Thank you for that. Excellent.
So this is a good male subject. Give me a, yeah, we're going to wrap up quickly. He's got lines, this, and then just relax. He also has heavy lids. And like a lot of males, if you treat these little lines on his forehead, he's going to look like this. So the better way of making these lines better is to decrease the downward vectors of force that occur from, give me a frown here, squeeze, from all that power going down, and then squint for me, and all that power from the lateral canthal line muscle, the orbicularis. And if we get those relaxed, it's going to lift his brow naturally just a little bit. We showed 5 millimeters in that study that I showed you earlier. And I'll bet this line, this is from chronic firing to compensate for his brow ptosis. And if his brows come up even a couple millimeters from treating here and here, he doesn't need a treatment here. So I would just, and they'll come in asking for this treatment, and I'm going to redirect them to where they really need it, and it's not on the brow. And my mantra in the office is that forehead line treatment is a balance between brow position and line effacement, or really a battle between them, and brow position trumps lines. So, and I would say that on every patient. So the worse your lines are, the more likely it is that your brows are lower, and the less likely that you want to even treat them, because you'd rather have better brow position. Now, there's some exceptions to those rules, but it depends on where your brows are starting. So for him, that's a better choice. And in the clinic and the spa, we have all choices, but in this case, Zeoman, I like to do 12.5, 12.5, and the same in the interbrow area with Zeo. It's the same cost then as Botox, and we do the same thing. So none of them cost any more. Zeoman's cheaper, so you can use a little bit more, get a little longer duration, everybody's happier. So I think in this case, we'll make sure this guy's happy. So give me a good squint again, and relax. I'll give it a little pinch. So if you can see the little vessels, we can avoid them. See and avoid is the goal here. 12.5, 12.5 on the two sides, and then the glabella, it's going to be the same. I'm going to turn this way just a little bit. 12.5 on this side, 12.5 on the other side. So he's getting 25 units in the glabella. A little bit, well, it'd be right on what the, I'd use 10 of Botox there, because then it all costs the same. So I don't have a stake in the game, and I encourage people to try these products. And you get a little better duration when you use a little bit higher dose, so that's really the main difference. Okay, so I'm going to grab your brow a little bit here. And what I'm doing is grabbing the corrugator between my thumb and forefinger, and I'm literally coming from medial to lateral and lifting the muscle away from the periosteum, little pinch here. And this is where most of my treatment is going, in the club head of the eyebrow with very gentle pressure. And I'm gently moving the needle as I do that. And then a drop right at the upper brow here is just a little stingy. And that's probably about 8 and 4 or something in that range. 8 and 4.5, little pinch here.
Just a reminder that the audience are using Zeoman.
This is Zeoman, yes. Well, then that's why, because it's less expensive, so you're not I'm making the cost equivalent by just using a little bit higher dosing, which gets happier patient results if you last longer a little bit, and a little pinch. And that'll do it. So he'll get a nice brow lift. He's young, so he might be one of the 5 millimeter lifters, and then he doesn't need to treat the forehead lines because he'll be more relaxed up there, not hiking his brow up all the time to get the weight off the lids. I'm not pressing real hard either, which is another thing I would tell you not to do after, even if you get a little reflux, because yeah, you don't want to bruise on the one hand, but you don't want to press this product around. This is 24 hours is where if you have them, it's a mistake to have people massaging or pressing down real hard. We don't want to push it into tissue planes that can get it in and around those nerves. The only thing I tell them they can't do is press on it. They can go to the gym, they can bend over, they can do backflips, they can go swimming. They can. The only, body position. There's no evidence that body position has any effect on outcomes, and there's also no evidence that exercise has any outcomes. I mean, you could theorize that there's more blood flow and potentially less binding, but I've seen no evidence to that in my patients.
Okay, we're going to go back to Dr. Mraz.
So we're going to do a Kybella injection. Picking the correct patient is really important with Kybella. You want somebody with some mental fullness, but without too much skin laxity. So Jenna has had, yes. Jenna's young, she's 43. She's had 8 vials of Kybella already. So what would you say the changes? I mean, do you even remember what you look like before you had your first?
Well, I'll be honest, like weight is an issue for me, and whether my weight fluctuates or not, my face doesn't get as full when I gain weight, so people may not notice. Which is awesome.
That's, well, I will say that when genetically someone has a full submental area, when we reduce that down, their friends and family suddenly start asking them if they've lost weight.
Yeah, for sure.
Yeah, for sure. Yeah. So, and we've discussed today that this mandibular sweep is such an important component of a beautiful face. So what happens, not only does that submental fullness detract from that, but often that little bit of mild gelling can detract from that as well. So what I'd like to do is, you want to be aware of your marginal mandibular nerve. Feel for the antegonal notch. And in 100% of people, the marginal mandibular nerve runs superior to the mandible, anterior to the antegonal notch. Now, posterior to this antegonal notch, it's a crapshoot. So about 1/3 of people have the marginal mandibular above the mandible, about 1/3 at the mandible, and then 1/3 down in the platysma. It always comes up at the antegonal notch, and in a lot of people there's a variable number of branches that occur as well. So understanding that anatomy is super important, and staying out of what happens if you treat Kybella where the marginal mandibular nerve occurs. You get demyelination and therefore paralysis of that nerve, which generally will come back, but it takes a while, and your patient is probably not going to be very happy during that time. So avoidance is key. I like to mark my patients prior to injection and feel for it. Go ahead and put your chin down. You can feel for the preplatysmal fat. So you really want to stay towards the skin above the platysma. We can do, I think she would love it if we did just a tiny bit at the inferior edge of her mandible, again, anterior to her antegonal notch, which is back here. And mark this area. She's got, you want to stay superior to the cricohyocartilage. You can kind of pull this area out a bit, which I think we will do just to give a little more benefit to that. Sorry, I just have to see what I'm doing here. And I love Sharpies. I don't love the black ones, but Sharpies wash off really nicely with alcohol afterwards. So they are, I think, a nice tool. So when I first started doing Kybella, when this product, actually before it was bought by Allergan, when Kythera had it, the reps came around and said, oh, it doesn't hurt that bad. The patients are fine. You don't need to numb them. Well, my patients who are tough as nails never wanted to come back for their second treatment because it burned like there was no tomorrow. So a little local lidocaine into the area does a couple things. One, it makes it so the patient has no problem coming back. It also increases that space between the sub-Q fat and the underlying tissues. So I like to use a 1-inch 30 gauge needle to infiltrate this area. You shouldn't hit resistance. If you're hitting resistance, you're going too deep. And this is pretty easy, right? Yeah. This really doesn't hurt the patient. I'm sorry, what's the question?
Have you ever tried adding lidocaine directly to the
Oh, a lot of people are doing that now. I have infiltrated beforehand, and one of the reasons is that it does take a little, I mean, so what is your experience? Do patients have any discomfort at all with lidocaine?
I put in 1 cc of lidocaine for every 2 cc's of Kybella, and used a similar 1-inch 30 gauge needle for
Yes.
my injection.
Yes.
And in some areas it doesn't really burn at all. In other areas there's a little bit of tingling, then it goes away pretty quickly. Most of the, I mean, I injected myself with it. And the initial burning is not bad at all because it kicks in pretty quickly. But with Kybella, like I agree with you, it burns like crazy.
Yeah.
But with that lidocaine, it's the afterburn that really goes away. And so for me, it's avoided having that 2 injection, time and making time go by a lot quicker.
Yeah, I mean, it's definitely more efficient. Usually what I do is infiltrate my patients with lidocaine, and then I do their neurotoxin, I do their filler, let the lidocaine infiltrate the tissue, because if they're not getting other things and I do the Kybella too quickly, often it still burns, which is why I think that doing it at the same time would be less comfortable for the patient. But I haven't.
It's been okay for us. So,
okay.
And because we've used that 1 to 2 ratio, if it's anything lower than that, it was still pretty low.
So 1 cc of Kybella?
2 cc of Kybella to 1 cc of lidocaine.
Okay.
So if we use less than that, then it will still burn.
Okay.
So it ends up being 3 cc's per bottle, basically, instead of 2 cc's per bottle.
Yes, yeah. Are there, I know a lot of people are doing that.
I do.
Mix.
That's great.
You do the mix?
Yeah.
Okay.
But apparently if you go higher than the 1 cc of lidocaine, you can alter the structure of the acid. So that's really
I mean, it does, so that was another initial concern was, this is an acid and you don't want to change the pH too much, but I have not had any patients that the Kybella hasn't worked on with the buffered lidocaine. So I don't know how much of that is, that theoretical risk is kind of comes to. Has anybody have any issues with that?
I know that the FDA trials, they used a lot of different, but they were trying to get it approved,
Yeah.
they were using a lot of different solutions to find out what was optimal, so I think that they work, but,
Yeah.
So we haven't had any trouble with effective efficacy.
Yeah. So I do like to have the patient put their chin down, and I do pinch the skin here. And this is another thing that is different. I no longer do the multiple boluses. I think fanning is a better technique. It's fewer pokes. The patients tend not to bruise, and you're infiltrating the fat basically with a cytolytic agent either way.
And what's the most volume, let's say you have somebody with a much heavier neck?
Yeah.
What's the maximum volume of Kybella they can do it at one time?
So 10 cc's or 5 vials was what they used in the, it's rare that, it's usually the heavier men who have wider jawlines that need more product.
And was there a shortage of Kybella this year?
Mm-hmm. There was at the end of 2018.
Did they just ask you to stop seeing patients for a while and you're using it all up?
Right. Yeah, that was, people were not able to, that was a problem. I guess for Allergan, that was a good problem.
Okay, well, that is great. And have you tried to shorten the number of treatment sessions that patients can be compared to when you first started using this a couple of years ago?
Have I tried shortening the number of treatments?
By doing more volume in your sessions?
Yeah, so I mean, I usually do have the discussion with patient, you're going to have swelling regardless. You will have more swelling if we do more product, but it's up to you, type thing. So, depending on patient, I usually, the first time, just so they come back, don't like to make them so swollen that they're not willing to come back, I guess. Okay, so you can see Jenna has instant swelling, and I do tell patients it swells instantly. Swelling is at its peak the day after, so it's going to get even a little worse. I do have patients ice, and swelling is a great thing. So we're instantly lysing adipocytes. This is deoxycholic acid. This is the same thing that your gallbladder makes to lyse fat in the intestine. So it's an instant effect. Your immune system takes no time at all to recognize that there are dead lyse fat cells in there, and basically comes in with a vengeance and creates instant swelling. So this is what we expect. This is a positive thing. This means that we've done what we need to do. So Jenna had 4 vials of Kybella today. She's had actually 8 in the past, so this will be 12 vials total. And of course, we don't have before photos from before the 8th, but, oh, you do, you have them, okay. But she's gonna be really happy with this. And pain level was?
A 1 or 2? Yeah.
Right.
Yeah.
Well, I think we've had a lot of happy patients today, and that's one of the fun things about doing aesthetic, injections and treatment, that we're generally dealing with happy patients. And I want to thank all of you who stayed for the last bit here and we do have a wonderful session again in the morning.
All of them go to all your
Case presentation. So thank you all very much. And thank you to all the staff.